With that framing in mind, this is where we're going this morning with our program. I put the highlighted bars in there so you can see how the day evolves. We're going to have a keynote that I've been trying to secure for the last 3 years. Dr. Scott Flynn, Regional Medical Director for Blue Shield of California, kick us off with a medical director's perspective from a peer organization. And I think you're going to love what he has to say. He's going to give you some food for thought that will keep us going this entire day. And then we're going to do what we usually do, which is give you an update on what's happening with this right now. Some things you'll know about, some things I'm sure you will not. If you're in a program, of course, if you're not, you'll quickly get up to speed on what the collaborators are going to accomplish. Really exciting is we're able to get updates from the 2 health plans that have been the most active in our program, Illinois Health Plan and LA Care Health Plan. And then we're going to have one of IHP's teams talk about this really exciting partnership we have with CDPH and their cardiovascular prevention program targeting post-stroke patients. I think you'll learn a lot from that presentation. After a brief break, oh, by the way, speaking of breaks, Dr. Flynn did point out to me early on that we don't give you many breaks. That's awful, isn't it? It's because if you need to get up and go to the restroom, get some drink, you can do it in the program. It's okay. We do have breaks, breaks scheduled and a lunch schedule, but our day is a lot of interaction. So we're not going to have you sit there and listen to me like you are now for very long. So please, if you have to use the restroom or get some drink or somebody, please do that. So after that brief break, we'll have a whole segment on patient engagement. And this is in response to some of the challenges that we heard you all say in regards to enrolling and retaining patients. We're going to have someone who you've all enjoyed hearing from, Dr. Wayne, talk about some of the essential tools that are helpful in engaging patients. And then right after that, you're going to have a great team of Jessica, Nancy, and Roya speaking about how to apply those tools in a telehealth format for the actual experience. But again, keep in mind, we want to hear from all of you about what works and what doesn't, so you can share that with the rest of the group. After that segment, we're addressing something that we've heard you all say is, bottom line is it's hard to get these patients to goal quickly, right? It's a challenge, it's very complex. So although what we're going to share isn't here and now, we're going to give you a view of what's ahead. It's coming very quickly in terms of resources and tools and methods to accelerate results from comprehensive medication management. We'll have Scott Mosley speaking about PGX, pharmacogenomics, and then Bob Tryon speaking about remote therapeutic monitoring using smart caps. And then we'll wrap it all up with some work we're doing with the state to help to advance diabetes self-management education support services for specific targeted local health jurisdictions. So this is for parts of the state that are really struggling with getting access to those programs. So LA is probably not really the one we're talking about, but at least we wanted to share some of the findings that she has and get some thoughts from all of you as to how can this be optimized for implementation in pharmacies. So our assertion is that CMM saves lives, saves money, and is a health disparity equalizer for high risk and emerging risk patients. And so the question we want you to run on as you think about this day is what key insights will you adapt to the organization to advance optimization of medication therapy for your most vulnerable patients? And so again, I already went through this. These are the kinds of feedback that we've received over the year that informed what we're going to be talking about today. I think what I did mention is that we have a little segment on data fidelity and documentation. You've heard it a million times. If you didn't document it, you didn't do it. But it has even greater implications in a collaborative like this, where that data is used for real-time quality improvement and for reporting back to the payer. So how do we need you to be? Some of you have been through this, but for those who have not, I'm going to make sure you understand. Our purpose today is to be interactive, focused on what I just gave you as a frame, the purpose of this meeting today. We want you to team up. So we have these tables with 4 chairs each because we need a small group discussion to happen. I want you to be actively listening and learning. Ground your thoughts, your recommendations, and proven methods that have worked for you. Challenge yourselves to think differently. And in the end of the day, we're literally going to ask you to talk about these things. What are some requests, offers, and commitments you can make to start to launch the work at following this the next session? So with that, we're going to introduce our keynote speaker, someone I've known for a very long time. Dr. Scott Flynn is Regional Medical Director for Blue Shield, California. He focuses on improving the value of care for Blue Shield's members. And prior to joining Blue Shield, Dr. Flynn was CMO at Arch Health Partners in San Diego, which is where I met him a while ago. He's a 22-year Navy veteran. His service included tours with the Navy SEALs, medical director at Naval Hospital in San Diego, surface forces surgeon in charge of healthcare on Navy ships worldwide. He's a graduate of University of Pittsburgh Medical School, board certified in family medicine and sports medicine, and earned his CPE from the American College of Physician Executives in 2013. And on a personal note, I really enjoyed working with Dr. Flynn in the Right Care Initiative under the direction of Patty Hanley. He's been a very vocal and strong leader for that group in advancing local and reducing pharmaceutical service for not just all Californians, but people across the nation. I thought the coolest thing I knew about was that he was a Navy SEAL. But you take a look at this. Anyone know what that is? He's like, this is Dr. Flynn's vineyard in California, where he produces 600 to 700 cases of wine every year. And the reason why he can't stay too long today is because he has to get back there. Because every Saturday from 11 to 5, they have an open house where we can go and visit. So if you're ever in Ramona, California, go by and check out his winery. I hear his wine is pretty amazing. He didn't pay me for that plug, right? All right. And with that, I'm going to turn this to Dr. Please welcome Dr. Flynn.
No.
This won't get started. That's fine. I can just use this. Yeah, that's fine. All right. I'm Scott Flynn, Regional Medical Director at Blue Shield of California. I've been there since 2015, so it's about 8 years now. In Blue Shield years, we say that's about 56 years. And I'm your expert for today. You all know what an expert is, right? Somebody who wants to the slides. San Diego, here's my slides. So, got nothing to disclose. Thanks, Steve, for the great introduction. Except for one thing, my daughter did go to UCLA, so it's good to see another team doing well in Los Angeles, and to help supplement the other two professional teams in Los Angeles, which are the Rams and USC. So being from San Diego, we have to say that as a Chargers fan. But anyhow, we're going to talk about our perspectives from a healthcare perspective, and I've been there for about 8 years. What are we focused on? What keeps us up at night from a health plan's perspective? First thing is costs. Right, costs are going crazy. You hear about this every day. Healthcare costs going up in the U.S. Kind of crazy. What's our second thing we're worried about? Costs. Costs are going up every day, rather rapidly. You know what else keeps us up at night? Costs. Really bothers us. And you know, when we're not thinking about costs, we're thinking about programs that can help to reduce costs. Right? Cost. Put in perspective, last year was not a good year for our company. We had approximately 10% layoff. So you see some companies reporting record profits and other companies are not. It was a rough couple of years with COVID, lots been around. If you have people that are working in hospitals that you know of, hospitals are getting crunched. The last Hospital Association of Southern California meeting I was at, about half of hospitals are operating in the red now. They had three things that happened. They lost some of the regular income they get from elective procedures with COVID, right? That's a big revenue generation from them. Nursing costs went through the roof. And nursing shortages, they were bringing in registry nurses. Registry nurses are making roughly double what the nurses they're working beside. So the nurses that were working there said, why am I going to work beside somebody who's making twice as much as me? I can resign and come back 2 days later as a registry nurse. So the labor costs went up. And the third thing that happened with them is the ER problems. The ER, the easy patients, quote unquote, the ones that would come in with UTI or a cough or a cold would come in and help pay the bills. Those weren't coming in during COVID. Everyone stayed away. unless you're really sick, right? So the acuity went up and the revenue went down. So they're getting a triple whammy on the hospital side, so they're kind of hurt. So where do they come to try to increase their revenue? The payers. So our costs are going up. We're trying to limit the costs because that's the healthcare premium is what really drives how we get our membership. And even as little as $10 to $20 a month difference in premium shifts people from one health plan to another. So it's a very cost sensitive environment. And that's the milieu that we're dealing with as we go through things. Here's an idea, another thing of what's going on in costs. Where does your healthcare dollar go? This is from AHIP, American Hospital Health Insurance Program. 22.3 cents is going where? Medications, prescription drugs. 9 years ago, that was about 9 cents. So pharmacy costs are going up through, no surprise there. The other costs there in terms of hospital, outpatient, facility, professional, those costs are staying fairly level, or just kind of rising at the rate of inflation. It's really the pharmacy costs that are going up. You can see here on the bottom part, that's all the administrative costs. So roughly in your head, if you have about 85 cents in the healthcare dollar goes to direct payment, the other 15% are administrative profit. At Blue Shield, we're a not-for-profit organization, so we try to get about 2% profit, which is last year obviously we didn't do because we had so many layoffs. And then we take that 2%, we reinvest it and give refunds, reduce premiums for our members. So that's what we do as a not-for-profit. So we're a little different than many of them, but that's how that works. So who's ultimately paying the bill for this? Well, it's the employers. Remember, health insurance evolved because it is a benefit to people that are working, right? It's something that employers use to entice you to stay with them. And that's what it really is. But our employers, is the health insurance that we're giving for the commercial population, is it the same as what Medicare and Medi-Cal are paying? The answer is no. As you can see here, for all hospital services, commercial rates are about 200% of what Medicare and Medi-Cal may be paying. For the hospital services, outpatient hospital services, and physician services, you see the numbers there. So it's really cost shifting that happens there. As a health insurer, we're paying much higher rates to help subsidize those that are government run or cash pay and keep the system going like that. So that's kind of how things work in the US. And this kind of puts it in graphically there. So it's really the employers and employees that are helping to support the dollars there. Well, the employers are saying to us, so what kind of value are we getting for this large amount of money that we're spending? Where's the value? Cover California started something called the Quality Transformation Initiative this year. Basically, they're putting our revenue that they give us, the premiums that they help to pay at risk. It starts at 1% this year and ultimately goes up to 4% of their premium risk in 4 years. And they're looking at 4 quality measures: diabetes control, hypertension control, colorectal cancer screening, and what's called CIS-10 or PEDS immunizations 10, the first set of immunizations you get in the first 2 years of life. And if you don't reach the 66th percentile nationally for both HMO and PPO populations, you get penalized. You actually have to repay back to cover California. So if you extrapolate those numbers out, it's literally tens of billions of dollars that we have just coming up over the next 4 years. So Cover California is really putting their money where their mouth is. And it's not a bonus program, it's a penalty program. So real dollar that's been. The Pacific Business Group for Health is also looking at, hey, what do we get value for our money that we're paying? And they're looking for different ways to do this too. I would not be surprised to see more initiatives like Cover California is doing going forward to see how we do this. So do they have a point here? And the answer is yes. So it's hard to see the countries on the bottom. Those are countries on the bottom. And the spending per capita on the left-hand side, this is from 2020 from the OECD. Who's number one there? Yeah, that's us. We're number one. We're the big finger on the far side. United States, far and away, spend much more money than everyone else on healthcare spending. Has it always been that way? Well, the answer is not really. If you look back at 1980, there's actually a little country called Switzerland that was higher than we were back in 1980. And we were relatively close. You see that accelerating line going up there. And this is data just through 2012. Well, that seems like quite a separation. What in the world's going on around here? Well, maybe it's because we're a rich country and it just seems like it's disproportionate because we're wealthy. So let's do it by percent of GDP. So when you do it by percent of GDP, we're still number one. That's us on the far right hand side. And if you look at it again, was it always that way? And the answer is no. Back in 1980, Switzerland was number one. We're the top line there. We've slowly separated ourselves from the rest of the world. We're paying much more in terms of healthcare costs than everywhere else. Are we getting value for that? Well, one metric you can use to see is the quality you're getting worthwhile for that, and the answer is probably not. So life expectancy at birth, you can see there's a whole bunch of folks that were grouped together there, and then what happened about 2000 or so, we started to fall off. We're the bottom line there. As you look towards the end, for the first time, you've heard this in the news a couple of months ago, our life expectancy at birth is actually dropping. That's us on the bottom line there, where it goes down at the end. So if that's one measure to see if you're getting good value for your dollar, the answer is we're spending all that money and we're actually getting worse. Our children's life expectancy is lower than what ours was. All right, another way to look at that is look at life expectancy versus how much you're paying for it, right? So on the left-hand side is life expectancy, that's in years. So the higher number where you go, the better. And on the y-axis is health expenditures. So what you want to be is as far to the left as you can, and as high as you can be. And you can see there's places like Japan and Sweden and places like that that have really good life expectancy for much less money they spend. We're the bottom line, going off and going off to the right. And again, you can see there at the very end, our life expectancy dropped a little bit as we were known by. So just not seem to get the value. So why? You can't read this in the back. It says if you can't keep up, we could go broke. Then you have to bail us out. And that could lead to European style socialism. That's a health insurer there. By the way, I'm going to make fun of everyone, including ourselves as health insurers. So as the public looks at us, we're all part of this healthcare billion, and they all look at us as we all cost too much money and we're not getting the value we want. Building on what Steve said about how people view our healthcare system, what we're doing, it's gone down. Part of that is a result of what happened with COVID-19. And just how people looked at how the public health recommendations were, and all that got up in there, and that's quite a big deal. But this is how people are looking at us. Probably seen this quote before. It's actually a tribute to a guy named Paul Batalden, and there's been copied by Deming and by Don Berwick from the Institute of Health. And so we've all heard this, and why we get the system, the results we get, because that's our system and that's designed how it happens. So what can we do to try to fix it? Well, pharmacy costs are rising the most. Remember, I told you back about 9 years ago, it was at about 9 cents on the dollar. That last one was 22 cents on the dollar. I think for us, it's around 25 cents for a healthcare dollar now goes towards pharmacy. Both pharmacy benefit and medical benefit drugs. It used to be 9 cents. That's an unsustainable growth. But how do you change that? Well, the only ways to change drug costs in America are twofold. One is either through legislation, which is a very hard thing to do, or through competition. And when you look at these particular things, there may not be as much competition. Orphan drugs and gene therapies, those are coming out. I'll show you a little bit about that coming up. Oncology. So, as you know, in health plan, what we often do with our drugs, we have preferred drugs, right? Or we do that through either step edits or prior auth criteria. And we can do that with just about every class of drug except for oncology. And when you're in health plan and you try to do that, what happens? You get beat about the head and shoulders, death panels, all that stuff. So we really can't manage oncology. Part of the other problem with that is if you're an oncologist group, what often happens is they get their drugs through what's called buy and bill. You're probably familiar with that. So they get these drugs and we cover everything that's NCCN 2A or above recommendation. So they have two drugs, one is 100,000 and another one is 700,000. And they're both 2A or above. We cover them both. The oncology group, they get buy and bill, they get 6%. 6% of 100,000 is 6,000. 6% of 700,000 is a lot more money. And there's no regulation or way we can manage that. So what would you do if you're an oncologist? They look about the same, yeah, we can use this drug, I'm gonna make $42,000. Now, I'm not saying it's a conscious thing they're doing, but unconsciously, you know that in the back of your head that buy and bill, I'm making more money by using more expensive drug. There's no incentive for me to not use more expensive drug, even if the research shows they're clinically equivalent. Nothing. Top sellers, we'll talk a little bit about that, but just think about what's going on with the GLP-1s and the SGLT2s now and diabetes. Very expensive, and the GLP-1 is just exploding with weight management, et cetera. Interesting stuff. And of course, the digital therapeutics, we're just getting into. Digital therapeutics right now, we feel we covered none of them on the medical benefit side. And the reason why, well, is there research that has outcome differences based on digital therapeutics? And the answer is no, there's not really anything that shows that. We cover most on the wellness benefit side, because there's some idea that this may help us as wellness thing, but not on the medical benefit side. Gene therapies, there's a couple of them, I think, as of today, there are 12 approved gene therapies in the US. The first one there, like tenderness or retinitis pigmentosa, is about $750 a pop. And that's the cheapest one by far. Well, Jessica, you probably know about it. It's for SMA, spinal muscular atrophy. That was the one that made all the headlines a couple years ago, came out $2.3 million a pop. It's now the cheapest of those other four up there. A couple of up there for hemophilia, Skysona, which is up there, is over 3.5 million of those. So how do you control medical costs? Well, it's competition. Is there any competition for any drugs out there or anything coming soon? Probably not. Is there legislation that's addressing this? Not right now. What are we gonna do about it? Well, we can use some legislation, probably familiar with the IRA that came out. This is nothing to do with Ireland. This is the Inflation Reduction Act that happened. And basically what it said was after 2022, rate increases for drugs can go up faster than inflation. Okay, so right before that, what happened, you can see on the second line there, the inflation rate was pretty high, then I think 25%, but right before the act took place, drug prices were up 31.6%. So manufacturers said, all right, let's get it in now before something happens. The other thing is, as you go forward, what would you do for your drug? Would you come in, try to give you the lower price and then have to be limited what your annual rate increase is? Probably not. You're gonna probably start higher, and then you can manage it that way and help secure your profits. And you know, from the pharmaceutical company perspective, think about it, what's their number one responsibility? Is to provide shareholder value. How do you provide shareholder value? By getting increased revenue. So they're doing what their fiduciary responsibility is, not necessarily their community responsibility, but their fiduciary responsibility. This is just another slide of how the timeline of the IRA is implemented. So it's kind of busy there, but 2023, that's where the rate increases were limited. And you can see as you go forward there in 2026 on, they start looking at different drugs and try to do rate control or pricing controls on that. But it's a small number of drugs, 10 drugs, 15 drugs, et cetera. They're obviously looking at high cost drugs, but let's not say it's a rapid ramp up of how we're trying to control costs legislatively. Can't read this in the back. It's these pills are $10 if you're paying for them, $200 if your company's paying for them. That's not true, right? In the back, you can't see that. Hey, whoever said free market capitalism is free, and out the front there is EpiPen. You all remember that about 4 or 5 years ago when the EpiPen prices went up to $1,000. Why? Because they could. There's nothing to stop them, right? It's a company that was actually headquartered where I grew up back in this little town called Gettysburg. Made record profits, and should we do anything about it? Well, let's not say this is all pharma's fault, right? This one says our health insurance company made 4.7 billion in profits last year. Coincidence, they're raising our premium again. Now, this isn't us because we're not for profit, but interesting thing that the public perception is out there. So what's the fix? Well, one fix is you look at what's there on the left-hand side of the slide. That's kind of how our healthcare value is right now. One solution could be single payer. It's a lot simpler and probably maybe a lot cheaper, maybe perhaps certainly simpler. And you have this opinion. Okay, well then, what's interesting? Again, is it just the government? Is it just pharmaceuticals? And it says here, what's with Let me see if I can. Oh, what's this with jacking my premiums up by 40%? Someone has to pay for the campaign against healthcare insurance reform, right? Because there's a lot of campaigning about just having one payer, Medicare for all. If your Medicare for all, that means 326 trillion, and you have to get above your insurance. That number was actually what, if you recall back in the election, I believe it, Susan Collins was the one trumpeting this, and they actually tried to do an estimate of what actually it would increase cost for the government, $326 trillion. That's not a made up number. That's what the estimate was what it would cost for a single payer. The pushback on that is, well, this is the thing we're going to put out there to maybe save healthcare instead of doing single payer. It's Obamacare there is the ones running the lifeline. And then, of course, there's always this. We're all from California, right? We all DV. So what can we do about it? It sounds like a lot of stuff going on, but what can we personally do about this to get better value in healthcare? And what is value? Value is quality over cost, customer-friendly manner. So how do you improve quality? Improve quality for quality's sake, because it's the right thing to do. But does improving quality actually decrease costs? And if so, how do we decrease costs? Well, if you're familiar with the Integrated Healthcare Association plan for the quality metrics that they did start back in 2003 with health groups, the idea was they got with payers, health plans like us, and groups, and said, if we do this, we think that by rewarding increased quality will actually decrease costs. And so they put up a whole program, a quality program that would review groups based on what the quality scores were. And that went on for about 10 years, and it helped to improve quality across a number of places. Didn't do anything for costs. The answer is no. If you want to control costs, you have to control costs. So they modified the AHA pay for performance thing, and now it's aligned measure perform AMP, and they've adjusted that so there's actually a quality cost threshold when you can't exceed increasing costs a certain amount as a gate you have to go through before you can get rewarded for your quality. But does quality actually decrease costs? The answer is maybe. We'll talk about hypertension control. So this is data from Kaiser, and they looked at doing hypertension control and seeing this could actually decrease deaths, major adverse cardiac events, so deaths from strokes and heart attacks. And what they found that if you got the ultimate bundle at the time, which is a base thiazide, atorvastatin 40, and an aspirin in appropriate patients, you actually reduced them 17% in 2 years. Now, I see some folks out there that aren't quite as old as me, got a little gray hair going on there. I'm 60 years old, just turned 60 this year. We all had friends or know people that died in their 50s from strokes and heart attacks in their 50s, right? Their prime of life, right? That's part of life, isn't it? Everyone in that 50s had. And they died from that, and it's oftentimes unnecessary, preventable. Why? Because they uncontrolled hypertension, uncontrolled diabetes. It's just a crime in 2023 to think there's people dying from heart attacks from uncontrolled hypertension and strokes in this day and age. We're the richest country on earth, and that's what we have. Again, to build on what Steve said earlier with the Right Care Initiative, what's the national hypertension control number? How many people think it's 50%? Raising hands. 75% control nationwide. Nobody. 40%. Yeah, it's actually 47% control nationwide. A couple of years ago, the Surgeon General initiated a call to action to try against control hypertension because it's brutal, it's criminal. 47% in the richest country in our hypertension control. What was the number one killer over the last 3 years? Was it COVID or was it cardiovascular disease? Yes, cardiovascular disease. COVID outfit cardiovascular disease for about 3 months and the peak of the pandemic. Other than that, it's been cardiovascular disease. Pretty amazing when you think about it, that we're not doing better than this. So how can we do better than this? We have the Right Care Initiative. This is one of the treatment algorithms that we promote from there. It's a pretty simple one that Steve was talking about earlier. 4 drugs, all generic, really easy to do. Can you implement this at your group, with your medical practice? The answer is sure. Can you do it with the help of a pharmacist? There's a thing called collaborative practice agreements, which would make it a legal way to do that. Sure, why not? Well, when I first joined my group that Steve was talking about, I was a primary care doc and did sports medicine too. But I was looking at our group's results and our hypertension control was very minimal. We were about 65% control on average. National 90th is 80% control. So our goal was to get to 80% control. One of the ways to get there is through use of collaborative practice agreements with algorithms like this and get them going. So we had a lot of resistance from the providers, and you may have seen this too, docs like myself saying, oh no, we can't let the pharmacy do hypertension control. That's a big deal. That's us doctors. We got to do that. So we said, interesting. And this is kind of when I became a believer in this. I said to the docs, I said, all right, we're going to do something here. I need a volunteer. I need a champion to come out and do this with me. And I had one of the internal medicine docs said, he'll do it. And I said, okay, I want you to go ahead. We're going to work with the pharmacist. We have one from Palomar Health and part-time, and he had a couple of pharmacy techs that were working for him. We're going to do med intensification using this algorithm with pharmacists and see what happens to your hypertension control numbers. So we went out and did it, and Dennis raised his hypertension control numbers from around 2% to 80% in 3 months with the help of a pharmacist. So we took it back to the board of directors, and also we said we want to present this at our quarterly meeting. And they said, okay. Said, but to do that, I'm going to probably show where everyone in the group, all 117 docs, where their primary care docs, where their hypertension control numbers are. And we're saying, oh, really? You're going to do that? I said, yeah, but I need your permission, right? Because they're probably going to get somebody going to be embarrassed if our peers. They said, well, yeah, you can do that, but let's see the list first, make sure we're not on top. So they looked at the list and none were on top. They said, okay, you can do that. So our next quarterly pharmacy meeting, our next quarterly providers meeting, and went up and said, all right, everyone, here we go. We're working on hypertension control, and I've got some solutions for you to help you. I need you to know where you are to start. And I put the numbers up there. And of course, the person who had the lowest hypertension control, 30%, was our cardiologist, one of our cardiologists, who was also a founding member of the group. So where's this? Scott? Yeah, Bill. Those numbers, that can't be right. Those were wrong. First thing I always do, write the data wrong. Well, Bill, actually, no, it's not. Of course, I anticipated the question, and I flipped up the next slide was all his patients. You look at that, it's a bill, these are patients. Here's the data. Looking at this. I don't know number 4 there. I've never seen that picture. I don't know who that is. All right, Bill, that's number 4. What about the other 198? Silence, sat back down. Of course, I just made an enemy for life. That's my medical professor's last 3 years on average. And I said, okay, Dennis, let's tell your story. What happened? Well, look, he went from 60% to 80% in that span of 3 months. What did you do? Well, use the pharmacist with the CPA and the pharmacy techs to do med intensification. That's all I had to do. And it was great. My next problem was I didn't know pharmacists because everyone wanted them. And that was the power of being able to do that and show that and say, wow, this stuff really works and it's very powerful. The other thing is we know there's a huge lack of primary care docs, and Steve shows the difference in hours they have to spend. They're going to try to be the hero, do it all themselves versus the team game. The team game works and makes everyone better. And there's not enough primary care docs, nurse practitioners, and PAs out there to do all this work. We need pharmacists there with us. Diabetes, same kind of idea. Now, this is the latest ADA guidelines. This looks very complex. When I present this for Right Care Works with different provider groups out there, it looks very complex, but really not. Because if you look at the bottom, ASCVD, what do you need? An SGLT2 or a GLP-1. For heart failure, what do you need? SGLT2. For CKD, SGLT2 or GLP-1. Glycemic control, GLP-1, SGLT2. Weight loss, GLP-1, maybe SGLT2. Pretty darn simple when you get right down to what you need to do. So it looks complex, it really isn't something that you can do. Does it decrease cost? Better control diabetes, you get less amputations, less blindness, less kidney failure, less cerebral vascular disease, cardiovascular disease, it all works better. CVD risk reduction. As you probably know, the following metric for lipid control, LDL on 100 went away. Oh, geez, probably 10 years ago now with ATP4 when it came out. But there are different ways to put people on meds when they should be on a statin when it's appropriate through this risk calculator. It was just outdated 1.5 years ago. It's still the way we're doing it. There are other ways to do it too, but this is something else where pharmacists can help. Does it work? This is what happened in San Diego. We started right here in 2010. By 2014, we reduced strokes and heart attacks down 23%. Rest of the state was falling not nearly as fast. That's the graph on the left-hand side with the lower numbers there being the right care, San Diego County. On the right-hand side, the good news was everyone in the state was improving stroke care better. And then follow-on study we did, published in Health Affairs, 105 fewer heart attacks, saving money, saving lives. In digital health, that's another thing that's coming. Does it work? Studies aren't coming out. As you know, in Silicon Valley, a lot of times you have a bright idea, build a little business, get it built out, get bought out, get millions. That's not how it works on the medical benefit side. We treat digital therapeutics the exact same ways we treat pharmaceuticals, show us the outcomes. And they're not there yet. They're still in their infancy of figuring out how this stuff works. So how can community pharmacists help? MedRec post discharge, we actually have a payment mechanism available for that at Blue Shield. Med intensification through collaborative practice agreements. We promote those with you with your local docs. And of course, CMM, as Steve mentioned at the beginning here, that's aspirational for us. We're still trying to figure that out, working on pilot programs on how we can better do that. Because we can't do it alone. Primary care docs can't do it alone. You need all your help to get this done. It's the right thing to do. And it's part of our basic core. This is our mission. We want to have care where there are family and friends. That's sustainably affordable. And that's what we're here to do. Thank you.
Okay, let's reconvene. We have Dr. Flynn here to respond to some of the comments. So who would like to share? I guess where's Lisa? Oh, Lisa, do we have a mic? Extra mic, yeah. We're going to ask for some sharing of your responses. I see Ramesh right up here. Please, I know everybody knows you, but please introduce yourself.
Hi, my name is Ramesh Upadhyay. I'm the Director of Pharmacy Services at the Hospital Outpatient Pharmacy in Palm Springs. So, Dr. Lynn, I got a question for you. So, like you said, Blue Shield now reimburses for the post-discharge under-consultation and also the collaborative services for business management. So we currently do that, and you say you have a payment for that. Do we need? How can we get credential with Blue Shield so we can actually bill for the services? Currently, which we are currently doing it free of charge.
Oh, and my understanding is that when you can submit a claim for that, they actually reimburse. I don't know what the rate for that reimbursement is, but it's actually in there with that claim of the right CPT that it's supposed to be getting reimbursed now. And I can get back to you on that, what that particular CPT code is, once I just email Selena and get that. But yeah, that free for the MedRec, that's supposed to be part of something we're already doing.
Do we need to especially get credential for that process?
That's a great question. I don't know the answer to that. My understanding is no, but I will check and make sure it may be on a certified list of providers who are allowable for that, where we bounce up on our claim system. Here comes a CPT. Here's an authorized person again. That may be the other part of the show.
So Ramesh, our team works very closely with Blue Shield and pharmacy side. They can tell you that you do need to be credentialed. There you go. Right. There are pretty high bars for it. Right.
Awesome. We'll reach out to Jessica.
Great. Thank you. Thank you. Other questions or comments, maybe from your discussion, your tables? Great. Please introduce yourself.
Hi, good morning. My name is Jackie. I was just telling the group here that whole idea of Southern California, they started that they'll stick with those 1, 2, 3 measures, and then they added the first 10 vaccines in the first year of the kid. The doctors, right, as far as I understood, will get penalized, correct?
No, it's actually the health plan gets penalized.
Okay.
So what happens is the 4 metrics, they look at, we have to reach national 66th percentile. How they come up with 66, don't ask me. They actually started at 75th percentile. We negotiated down 66%. And there's 4 metrics, and there's both HMO and PPO. All right, so the free range chickens out there running around, the PPO members, right? They're all running around free range chickens. We have to corral them and get them in also. And look at all those quality metrics. The penalty comes to the Southern California, as you know, supplements premium, that they're the payer. And they're paying us, and then we pay the providers. They're taking 4% off of what they pay us. So it comes to the health plan as a penalty, not to the provider.
But can you please add the provider? Or add the provider, because the problem is we pharmacists wants to do CPAs with providers. The problem is the providers, not the pharmacists.
Concur 100%, and as part of what we do is our education programs, and what I'm doing with Right Care is advocating for CPAs, and we're trying to do that also from Blue Shield perspective, not just through Right Care, but other ways. Is there's a resource out there that can help you, and part of the inertia, frankly, we see from providers is the same thing I experienced when I was at my group. And this is funny. This is the other thing I didn't tell this part of the story. So we showed what happened with Dennis, how his hypertension control levels went up and everyone liked it. The other resistance is, oh, right, oh, you can't do that, that's hypertension, you know, that's doctor work, blah, blah, blah. You can't let pharmacists do that. And I said, don't we have a community clinic care? Oh, yeah. Okay, and this is when the different pill acts are just coming out. So we have community clinic, and we have all these novel oral anticoagulants coming out that are literally life-threatening meds if you mess them up either way, right? They get too low of an INR and they clot, or they get too high and they bleed to death. They're working life-threatening medicines for you, and that's okay. It's really no doc likes dealing with that. That's just a nightmare. We hated tracking this INR. What did you have at Saturday last night? Okay, repeating, and here comes the INR of 10. Everyone, general alarm. That's okay for pharmacists to do, but not hypertension. Really, guys? What are we doing here? So it's provider inertia also. We try to overcome that. And that's a big part of what to move. But it needs to be moved.
Okay, but the concept that Covered California is doing, I know you clarified it, that it's gonna, the penalty gonna go on the insurance and all that.
Right.
But I would love to suggest that same concept goes that on providers as well, because we get penalized on the MTM. 1 second. Seriously. We don't get better reimbursement in the whole DIR fees that killing us. And it's not really our fault, but the insurance company doesn't see that. They only want to see a 30-day bill, but they don't want to see the doctor retire, the patient need to make, or whatever going on, you know? And I end up being penalized for less reimbursement, less quality rating, and everything goes down. It's not my fault, really. Like we put all the work, we go, we try to get refills, that is better, we do the patient. We do everything. But at the end, it's like we end up being penalized. Okay. Underpayment and the star rating goes, and you know the whole sequence. What about the doctors? I'm not against the doctors, but it takes 2 to tango, you know, I mean, it should be fair 50-50. So
it takes 3 to tango, actually, because we got to be in there too. We're helping to get the providers on board.
Correct, but I would love to see the insurance companies penalize doctors. For instance, like those 4 measures to make sure, as an example. You said the health plan, the first 10 vaccines in the first year of the kids' life.
First 2 years, yes.
The first 2 years. How about we apply that same concept, like the main 2 for any adult 50 and above, the shingles and the pneumonia, for instance. If this doctor is not making sure his patients being vaccinated, you know, it's better be safe than sorry. It's preventative, right? It's gonna cost less because XYZ is not gonna end up with pneumonia in the hospital. It's just costing more than insurance, you know, and the whole thing. So this is where we can pitch in. Okay, doctor, let me help you make sure all your patients are vaccinated or compliant. This will give you better rating, that, and then when we get resistance or non-compliance, or they don't believe in us, they want to do everything by themselves, like you said before, then I think they should deserve a little bit of penalty as well, right?
I have this question, Scott. I think your organization does have P4P type metrics for your providers, right? That aligns with what you're saying somewhat.
Yes, three things for you. First of all, we do have programs like that, both in the IHA P4P we talked about, and it's pay for performance, and they're measured on those metrics. The beauty of the covered California is they pick 4 metrics. With the IHA P4P, it's 24 metrics. So each one of those 4 metrics that cover California is part of that. But when you have 24, it dilutes what you're trying to do. And that's why we're very happy to cover California only picked 4 and picked 2 that were very near and dear to our heart with diabetes and hypertension control. They picked colorectal cancer screening as the preventive measure because, and not breast cancer, because it affects both sexes, not just females. And they picked the CIS-10 pediatric immunization because that's a very comprehensive one for that first years of life. So we're happy to cover California, picked only 4. When that's first point is, yes, we already do that with IHA P4P as actually a line measure perform AMP. We also do with our ACO contracts, where we put money at risk for the doctors with a quality bonus or a quality incentive in there. Many provider groups aren't willing to negotiate in and take downside risk on quality metrics. So, and the third point is, Steve already talked about provider burnout. We've got primary care docs leaving in droves because you saw the hours they're putting in, and yes, pharmacists are part of that re-engineering to help solve some of that stress and putting them in there. But most are like, I'm done. I'm fed up. No, I'm not taking any downside risk or anything. I'm up to here, back working 12 hours a day. I'm making half of what the dermatologist down the street is, who has no weekends, no nights, no calls, no holidays. Well, why am I doing primary care? So we don't want to go out there to beat primary care head more because they're already beaten enough. That's philosophically why we don't really push that.
Something to make them more excited, more open to bring this on board.
Yeah, and that's why we're doing the quality incentives. And also we're looking at different ways to the comprehensive med management and more CPAs to get docs working with pharmacists better, because you are part of the Institute of Reengineering. Absolutely have no doubt about that.
So I was just gonna sort of after that point, you may be already familiar that the health plans that we work with currently in this collaborative are doing much of what you're talking about, right? There are P4P type of incentives that are in the mix with their physician providers. And what we do is we line up the services provided by the pharmacists with those P4P metrics. So there is excitement, there's synergy, there's interest in doing this. So you bring up a great point. These are the pain points that all of you are feeling, and it's the theme of what you're asking to talk about. So thank you for bringing it up, and we will further this conversation. We're actually out of time for this session. So thank you very much. Okay. And then, again, let's give Dr. Perry time to take it. So before we transition to our next section, we need to bring up Dr. Richard John, president of the California Pharmacists Association, to say a few words. And we wanted to thank the California Pharmacists Association, Dr. Dave, Susan Benet, and others for allowing us to partner with them on this, providing this meeting to you. So with that, Dr. Dave.
Thank you, Dr. Joby. Hi, everyone. So my name is Richard Yang, and I'm also joined by Dr. Melissa Kimmer, who is our incoming president-elect for the California Pharmacists Association as well. So on behalf of CPHA, we wanted to welcome you to Las Vegas and our annual conference at the Western Pharmacy Exchange, and we're very excited to be able to also host the CRMC spring annual meeting. You guys have a really great schedule and agenda ahead of you, and you guys are all doing such really great and amazing things that as an association, we're really excited to be able to support. As you know, we have some really big legislative items that we are addressing this upcoming year, including payment reform for pharmacy clinical services, PBM reform, as our kind of top 2 items, and addressing HIV PrEP and PEP as well for furnishing. We hope you guys have a really great conference today, and we hope that you're able to stay the rest of the weekend for our Western Pharmacy Exchange as well. We're excited. It's a sold-out conference. It's a very looking forward to lots of great discussions and networking items throughout the rest of the weekend. And Dr. Kimura will talk to you about a few receptions that we have if you are going to be able to stay for this weekend for some of those who are pharmacy owners in that space.
Thanks for sharing, and thanks everyone for being here. As Richard mentioned, my name is Dr. Melissa Kimura, and I am the incoming speaker-elect for CPHA, or president-elect, sorry, past speaker, incoming president-elect, that will get sworn in tomorrow. So a few receptions, as we mentioned, if you're staying the weekend with us, for our pharmacy independent owners. We have the CPAG, or the Community Pharmacy Advocacy Group reception this evening, between 7:15 and 8:15. So reach out to one of the board of trustees who have an orange ribbon, and we can direct you to where that is. And then tomorrow, Saturday, from 3:30 to 5, we have a owner's reception by AMBA, our insurance sponsor. So that'll be out here in the Versailles one. So we'd love to see you at either of those events if you're an independent owner, and have you stay here with us through the weekend. Thanks for being here.
And my card, my information is on the table, and Steve has my information as well. And you can definitely share that if you need to contact us for information about those receptions. Thank you all. Looking forward to seeing you this weekend. Thank you.
Yeah, we're super grateful that CPHA is so supportive of what we're trying to do with this collaborative. And it's very much been in tune with legislative needs to support this work. So thank you both for being here. Okay, so I'm going to just kick off the next segment with some updates on what's happened since our last Lorraine session, which is again spring of last year. And I'm going to cover these elements here. Some of the changes that we made to training, our partnership changes, impact analyses, grant opportunities, and some data management issues to be covered by our quality improvement experts. So some of you are familiar with this, most of the one, as the illustration of the process used to train pharmacists as part of the development collaborative. And this is tailored back to the Institute of Healthcare Improvements Breakthrough Collaborative Series process. Basically, it entails a couple of live learning sessions every year. And again, I mentioned at the top of this meeting that in spring we have to focus on physical health, in the fall we have to focus on mental health. But then just as importantly, throughout the year, which we have all sorts of things going on, including monthly webinars that focus on everything from disease management to patient engagement, working with the health plans to identify how to connect patients to social needs resources, continuous quality improvement, a lot goes on. So those of you that are our teams in our collaborative, you know there's a lot going on. And it's to make sure that we're able to deliver the value that the patients are seeking, as well as the value that the health plans are seeking. So the new addition is, as of last fall, we launched that integration of the mental health focus. We have something called the Psychiatry for Population Health Pharmacists Collaborative, the purpose of which is to instill our collaborative team members with the knowledge to manage medications for patients with mild psychiatric disorders, anxiety, depression, and the mild end, and be able to recognize that patients move more to the moderate severe range. Recognize that they're at that point. Number two, how to connect them with the right healthcare provider to address their mental health needs. So that's one aspect. The other is because thanks to our partnership with partnership with LA Care Health Plan and IHP, there's a very rapid expansion underway to expand the population that's eligible for enrollment in the CalRETS collaborative. So we're moving away from our pilot or demonstration focus areas of diabetes and asthma to patients that are post-hospitalization for cardiovascular diseases, for stroke, and mental health, which is why we have a mental health piece as well. So this has resulted in a lot of changes to our monthly webinars, where we have much more challenging topics that are being shared by experts. Covering MI, stroke, CKD, other related heart failure conditions that you're going to see much more of as this collaborative continues to evolve forward. And we're going to continue to do that, share cases, share best practices, and make sure our teams are very comfortable working with these very challenging patients. I mentioned before that our partnerships have expanded. Some of you have seen this graphic in some version before, but there are some additions that I think are worth noting. Dr. Flynn and I serve on the steering committee for the CDC National Hypertension Control Roundtable. The goal of this organization is to reach 80% control of hypertension by 2025. A little ambitious, Dr. Flynn, I'm sure you'll agree. But all the right people are at the table. This is a national organization. They're looking for all the experts and best practice organizations that want to be a part of this. And they're very thoughtful about how to move forward with that goal, with specific strategies that move the needle. And I think my impression is that they're very excited about the work that we're doing here in the Cal Witness Collaborative. They view it as one of the few models out there that is value-based, that's driven by results, and is community-centered. It's highly accessible to patients in the communities that they live in, especially those that are vulnerable and from minority populations. I think I mentioned before that we are starting to work with Healthcare in Action, which is a subsidiary of SCAN. That's progressed quite a bit now. If you look on the far right, that's a picture of Sean and Ann Lee, their organization called CORE, Community Organized Relief, or organized, I forgot that R stands for. Anyway, the bottom line is they exist to deal with major crises around the world, literally. And here in LA, they've been commissioned by Mayor Karen Bass to help to support and really fill in the gaps in street medicine programs that are serving the homeless in Los Angeles. So the sort of the quick bottom line is there are about a dozen street medicine, maybe more than a dozen street medicine teams that serve the Los Angeles area. They meet regularly, but they don't necessarily coordinate care with each other though. And they're all great, they're all doing great work, but they're all doing it, I don't want to say in silent, but also with pieces that are not quite complete to make it all flow well. So CORE's not there to answer all the problems that exist in street medicine. They're there to listen and try to fill in the gaps as to what's missing. And one of the things they identify early on that's missing is a strong pharmacy partner, not just to make sure patients get their medications, but to provide follow-up care, to provide long-acting injectable antipsychotics, to do CMS. And so what we've been doing with CORE, HIA, and now 96 Pharmacy is to start a pilot as to what a best practice model would look like between street medicine, pharmacy, and CORE as a at least initial supporting organization, with the goal of making sure that that partnership is sustainable and provides high-value services to the patients and the team. So we're really excited because CORE is going to help fund part of the pharmacist for the next year to work with these programs. And within that time, we're going to co-invest and come up with a best practice model that we believe will be sustainable and scalable. Other elements, as I mentioned before, the California Department of Public Health has been working with us now for maybe a year, right? On a post-stroke CMM program piloted by Ramesh and his team over at Desert Outpatient Hospital Pharmacy, Hospital Outpatient Pharmacy. And it's really exciting because it's such a high priority post-COVID. As you know, stroke rates have risen tremendously, as well as other conditions. But this is a real crisis for the state and the nation. So we're really looking forward to furthering that partnership. Ramesh will provide an update as to what's going on with that program. But that's one of many. You should know that CDPH is really excited and supportive of the idea of community pharmacies becoming these health and social services hubs and extending care to the higher risk patients in their communities. Maybe a couple other highlights. That is the University of Charlotte that you see down there. We are in discussion with them to have them join our collaborative. And you might think, why would the UAE have an interest in our health collaborative? When we met with them about a year ago, we were astounded to hear that their health issues, public health issues, and general healthcare issues are very much in parallel to what we're seeing. Metabolic syndrome, mental illness, challenges with reaching patients in their communities. They are very much like us. So we're really excited to see if we can partner with them to help transfer or help them adapt what we've created here at the CRMC Collaborative. And they've discussed the possibility that if they're successful, this could be something that the government then adopts. So we're excited about that partnership. We are reaching out to Kenya They also have an interest in joining the collaborative. Initially, their interest was in tropical diseases and rare conditions, which, that's not our expertise. But about a month ago, in the New York Times, an article came out that basically summarized the fact that the life expectancy years that have been gained in Africa over the past decade or so are being wiped out by higher rates of hypertension and diabetes. So there really is a lot of interesting parallels between their needs and what it's to offer. So just a few highlights of expanding collaborations that are occurring through the California Advanced Collaborative. This is LA Cares, Alex here. This is their great work and the partnership that we have with them, and all of you pharmacies that are responsible for this. So at least the latest pre-test, post-test results are pretty astounding. Right, A1C reductions of 3.3 points from baseline, systolic blood pressure reductions of 34, and that's a big number. I haven't seen very many organizations produce these kinds of results. And then statin utilization, which was 42%. Remember, when we first started our collaborative, up to about 90% utilization of people with diabetes. So it was this work, the hard work of Nancy, Alex, and others that convinced LA Care to expand the enrollment population. Other efforts that are going on with our collaborative is we're conducting very rigorous impact analyses of the work that we're doing. At the end of the day, pre-test, post-test is interesting, but it doesn't really convince the most skeptical peers as to what the impact of the interventions are. So we have these very rigorous control comparison group analyses that are going on. One of them with LA Care is in partnership with the CDC and NORC, specifically looking at the telehealth component of what we're doing. And then Desert Oasis has reached out. We're doing a very extensive analysis with our team, led by Dr. Stephen Fox and Dr. Vita Shaw. And then again, we're trying to grow and support this with all of you. We are going after grant opportunities. LA County Department of Public Health has been remarkably supportive of advancing rural pharmacists and CMM. As you probably know, we were able to launch California with a sizable grant from LA County through the CDC. That grant is ending this September. Now there's another grant coming through. And so now we're applying for those series of grants to hopefully extend this work going forward. We did complete a pre-CORE grant submission in January this year, basically to test and evaluate what happens when we combine CMM and collaborative with telemonitoring. It's not a $9-10 million grant. Hopeful that we'll get something, but we'll see. It's we were at least invited to apply, so we have a little shot. And so I just to kind of wrap up my hand off to your Emily's Wilkins. Somebody once asked recently, what are some of the keys to advancing pharmacy practice that we need to address? And I kind of laid it out in 5 pieces. It's aligning with patient and health system priorities, it's evidence, equity, education, policy, and legislation. You can see the different components in there. Under alignment with payers, value-based arrangements, key performance indicators, pay attention to those. Whole person care, patient safety with evidence. It's what I just shared with you. We need these rigorous impact analyses that get published in non-pharmacy journals, because when we publish in pharmacy journals, only we look at it. People like Dr. Flynn don't look at it. It doesn't really make an impact. Equity, very, very important. Every single endeavor in the state and nation from a government healthcare perspective is very heavily focused on narrowing health disparities. The education part, in essence, is aren't you a bit tired of trying to explain what pharmacists do besides fill prescriptions to new stakeholders? And we really need an end all of that. And I'll just comment on that really quickly. Dan Kuno, who's the current CSHP president, has a good friend who's an Emmy Award-winning documentary producer and has volunteered to direct a documentary on what pharmacists really are. And it's not going to cost that much. We're in the fundraising mode right now. But it's really going to focus in on all the things that you are probably tired of explaining in regards to what pharmacists do, besides extensive medications. So actually, the last comment I'll make under policy and legislation, you can see that I wrote we need to accelerate state and regional efforts to change legislation. Federally, I wrote "Don't hold your breath" because I've been in practice for over 30 years now. When I graduated pharmacy school, I was told this year pharmacists want your provider status. This is back in 1990, right? So I'm just somebody cried wolf 20 times. Maybe I'm a little jaded, but I spoke recently to Dennis Wagner, who's was the outgoing director of quality for CMS, and I asked him, in all honesty, do good pharmacists get providers tax? He said, no. He said the government is just too afraid of costs getting out of control. They're just probably not going to do it. But instead, they recognize the value of pharmacists in collaborative team practices. And if you look at all the quality-based initiatives coming out of CMS, most of them have a strong component where medication therapy optimization is key. So the bottom line is that creating those opportunities for pharmacists to participate, but we're not quite ready to pull the trigger on their status. So I share that because now, if you look at the highlights, this collaborative is very actively involved in many components of what I think are key to advancing pharmacy practice. I was able to share your work this last year with Richard Gang and others to the State Board of Pharmacy in an effort to try to modify some of the practices of how pharmacy is regulated in the state, specifically standard of care. So I can tell you that we had a whole 45-minute session. Alex was part of it. Thank you for participating in that. And I think it was very enlightening. I think Alex will agree that the questions that we got on the board showed that there was a pretty big deficit in their understanding of what CMM is and what you all are doing. But when they were done, not only were they excited about this, they asked Alex, can you work for other parts of the state as well? And they just loved his vision for what pharmacy can do. So thanks again, Alex, for doing that. Okay, with that, I'm going to bring up our quality improvement specialist. And I'm underselling her by calling her quality improvement specialist because we have her do everything. Annalise Wilkins has been with us now for several years, and we found her to be remarkably talented. She's going to share some of the challenges that exist in the effort to conduct quality improvement, and some of the things that you should be paying attention to help facilitate this, to ensure that your work is well recognized. And so I'm going to bring her up here, and please welcome Dr. Wilkins.
For the introduction, my name is Annalise Wilkins, and I'm the quality improvement specialist for the California Red Cross Cooperative. Today, I will be discussing our transition to our new data platform, Irene, and the importance of proper data documentation. So CRMC originally used USC's homegrown platform, Cafe, but as we expanded, we needed to transition. And in January of 2022, we transitioned to Irene, an AI healthcare data aggregation platform. Since all of our results and studies are driven by complete and full data, it's very, very essential that we have a platform that has the bandwidth that can sustain our growth. And one aspect of the data documentation that is very important is our QI report card. So CRMC has always created a QI report card. However, with Cafe, it fell onto the QI specialists to actually pull the raw data and calculate the averages and whatnot. But now with Irene, it's automated. So at any moment, I can log into the Irene platform and easily pull the most up-to-date snapshot of the metrics we track. And at the moment, these include patient enrollment, patient visits, medication-related problems, stat utilization, hemoglobin A1C, blood pressure, and patient graduation, which is a new 2023 edition. Having the report card built into the platform has really streamlined our QI process, and it allows for more time actually verifying the data than just computing the averages and creating the report. So the monthly QI report cards are sent to the health plans with all the metrics I just mentioned. These report cards allow us to see a clear picture of the data so that we can assess it for completeness and accuracy. Since we were looking for trends in the data, especially with A1C and BP, we are able to see if the CRMC visits are actually controlling patients' chronic illnesses. And for example, this is a screenshot from one of our report cards. It's a de-identified pharmacy, Pharmacy A, and it tracks Pharmacy A's patients' A1C averages from their first visit all the way to their 6th visit. And as you can see, the average A1C of the first visit was about 10.7, and by the 6th visit, it was lowered to 7.5. And there is a spike in the 3rd visit, so it's not always exactly a downward straight line, but the overarching trend is downward, which is exactly what we want to see. As patients have more CRMC visits, their A1Cs are more controlled. And similarly, for blood pressure, this is tracking patients' blood pressures. And in the first visit, only 31% of patients had a blood pressure of 130/80 or lower. But by the fifth visit, 100% of patients had a blood pressure of 130/80. In addition to tracking trends at the pharmacy level, we also see if there's any commonalities among the pharmacies. And for this screenshot, we're looking at the percent of patients who have at least one blood pressure documented. Looking at this table raised concerns because it looked like pharmacists weren't capturing blood pressures at as high of a value, as high of a rate as we had wanted or expected. But luckily, since we noticed the trend, we were able to easily recognize the problem and take steps to fix it. And for this specific case, we completed a blood pressure recon analysis with pharmacists from all CRMC pharmacies and discussed barriers in collecting blood pressures and tools to overcome roadblocks. So proper documentation is vitally important, and I want to highlight two main reasons. The first is that the fidelity of data entry is integral to drive positive patient outcomes. As I mentioned in the previous slide, we use the data to analyze trends to drive positive patient outcomes, and we need full sets of data to correctly analyze these trends. Second, and Steve mentioned this, is that rigorous impact analysis is reliant on complete and correct data. We need our data sets to be as complete and large as possible to ensure any treatment effects will be statistically confirmable. There's power in large numbers, and when data sets are incomplete and don't have power behind it, the study designs are weaker. So hopefully you can see how important proper documentation is for CRMC. When we have enough data documented, we can create a QR report card, which is a tool we use to verify and analyze trends. And when there's a trend that arises that concerns us, we complete a recon analysis, and we can speak to the pharmacists, then implement corrective action plans. And ultimately, this will lead to positive patient outcomes, and the cycle restarts. And this brings me back to our data platform, because we wouldn't have data to analyze if we didn't have a centralized system to store it. So circling back around, I want to talk about some of the successes and setbacks we had last year with our transition. So to start with the successes, as I mentioned, the automation of the QI report card. It's been a really big one. It's changed the whole QI timeline a lot. Additionally, CRMC has a very collaborative partnership with Irene, which is a nice bonus because we meet with them every week and we're able to go over any issues and work together to correct them. Finally, Irene also just has the bandwidth to help CRMC as we continue to grow and partner with new pharmacies and health plans and have a bigger patient population. That being said, there have been some setbacks, and these include the learning curve for pharmacists to familiarize themselves and get trained on a new platform that was very different than Cafe. Additionally, since Irene wasn't made solely for CRMC, there are some universal questions that are present across all partnerships. So we can't edit every single question to the exact wording we want. But that's understandable considering how big Irene is and there are many partnerships. And finally, at the moment, the data exchange between our health plans and Irene is not yet fluid. There are additional features within Irene that we haven't even been able to use yet. So we're looking at our health plans to hopefully open up this door. And if we get this goal achieved, user errors will be further mitigated. Since pharmacists currently need to manually input patient demographic information and health plan names, this opens the door for user error. But if the data exchange was more fluid, this would help prevent violations such as HIPAA violations. And finally, looking forward, as I just mentioned, we plan to continue our collaborative relationship with Irene. We want to build out additional dashboards for additional disease states, such as asthma and COPD, among others. And we're really looking to hopefully open the door for data sharing between our health plans and our plan. And most importantly, we strive for complete and proper data collection. We're really dependent on the data that we have to ensure that we can have positive patient outcomes and to conduct future rigorous data analysis. Both of these will show CRMC's value and our success. Nothing's different. Thank you.
Anyways, thanks so much. I don't even think that reflected the amount of work that Annalise and Jessica and others have put into the data partnership with Amy from Irene. Amy, thank you for being such a great collaborator. I know, but let's just be honest. We know you guys are upside down from actually working with us, so we greatly appreciate you being able to do this and it aligns with your core values and beliefs. So look forward to continuing this process. Okay, so with that, I'm going to now bring up what I think is always a highlight of this meeting, and that's to hear from the two most engaged here at this point in terms of actually having pharmacists that are more involved in job like this. And that's LA Care Health Plan and Illinois Health Plan. I think Dr. King will be first. Am I right? No, there's two Dr. Kings. Okay. Alex, is it going to be you first or Connie first? Does it matter? Okay, they're deciding right now, so you can tell that they're married. Okay. Well, I'm going to introduce both of you. How's that? Okay. So, Dr. Alex King is director. No, actually, this is an old bio. Sorry, he is now executive pharmacy director for LA Care Health Plan. Just recently promoted, so let's congratulate him on that. We're really excited. I've known Alex a long time. I think this list of what you do is probably not correct now. You pretty much run everything now for pharmacy at LA Care. So maybe I can just leave it at that. But I'll give you a little of his background. He did complete a residency program and a residency program with Health Net. And as he likes to say it, I love reading this part. He's been hired, fired, and laid off from various health plans in California. And he likes to keep it real, which we always appreciate. I think he's trying to get another 5 certifications, but he is an advanced practice pharmacist, board certified in pharmacotherapy and care geriatrics. But he respectfully asks that if you have any clinical questions, send them by email so you can look at them later. He's busy as a administrator right now. He completed his MBA at UCLA not too long ago. I think it was just a couple of years ago. But he refuses to attend the E class because he attended USC for his undergrad degree in chemical engineering and chemistry. He's been a wonderful partner, fantastic leader, and a tremendous supporter of pharmacy, particularly independent pharmacy. So with that, let's bring up Dr. King. Welcome.
Hi. So the reason we had the update was that some of you that worked with us at LA Care, Yana was my old boss and she just retired. So it's a good thing. She bought a house. She literally bought a house in the south of France. So don't pity her. She left that time ago. So I took over as chief pharmacy executive at LA Care Health Plan. It's my first month here and we're just getting things started. So been with LA Care for about 7 years now. So just like when you were talking about like how many years that in LA Care years, that's about 40 something years also. So it's been a long time. The main thing for us for CRMC, as we as some of you work with my health plan and my HP, is that first and foremost, we had the questions about what can we do as a profession as pharmacists? And first and foremost, I'm a pharmacist myself, so I want to make sure our profession is taken care of and it's advancing. So then we talked about pay and money and cost. This is costing us money, but at the same time, we're helping so many people. Like the goal that we have as a health plan is we don't see patients one at a time. We try to make changes that affect the whole population, right? And that's kind of where what we do as a health plan. And while this program, what we see as a vision is that we're going to spread it out and we could have multiple pharmacies do it so that we could have a bigger impact, because I can't personally do this one by one, right? But if I have many pharmacies and many pharmacists that can do this, and hopefully it spreads, right? Because the good example that we always give is like the vaccination programs, right? A long time ago, when pharmacists first started vaccinating, it was crazy. I really, oh my gosh, well, the pharmacists are going to start vaccinating now. It's physicians' office don't even stop vaccines anymore. They just tell patients to go to the pharmacy to get the vaccines. So the next vision for us is as we take care of patients with diabetes, hypertension, the physician is eventually hopefully will say, well, we don't do this out in our office, just go to the pharmacy and they'll take care of it for you. So that's how we're gonna control diabetes and blood pressure in a more faster and more repeatable and more easier way for the patient, right? Because we've learned from COVID, right, that now that with telehealth and with pharmacy home delivery, that convenience makes a big difference for the pharmacy for patients, right? And it's not just drive-through anymore, right? Where mail, it's actually convenience at the retail level. And as being in LA County, a lot of you here are independent pharmacies, and we do love our independent pharmacies, right? And I'm going to tell you right now, we're a big supporter of independent pharmacies for various reasons. Number one being, at LA Care, we're a very diverse population of patients, and I do love that all our independent pharmacies speak various languages, not just Spanish, it's just every other language in between here in Los Angeles. And the main thing for me is that I'm a big supporter, and as we, I'm just giving evidence, we have an independent auditor that audits us, right? For our rates, for example, how much we pay to independent pharmacies. And what they told me is, hey, you guys pay pretty well, and we could probably save you some money if you adjust your rates. And the first thing I told them was no, because I don't want to be, it's not a race to the bottom, right? We know that as pharmacists, we know it's not a race to the bottom. If you pay, the less you pay, the less quality you get. We see that in everyday life, right? When you look for something, when you buy something of quality, you pay more money, right? So that's what we're going for at LA Care. We don't mind paying for quality, and that's what we're seeing with the CRMC program. And I think as independent pharmacies that are in the CRMC program are showing that the quality, the reach that they're having is so much greater that it's worth the cost. So it's actually a very good bargain for us. The amount of money that we spend to bring when someone has the A1C control, like the studies, like the results are showing. And I know, we're paying you a decent amount, but it's actually a bargain for us. So when, as other plans see what we're paying, it's actually an overall, it's a good price. So we want to pay for the quality. So as you see these reimbursements rates go down throughout the from other organizations, know that for the independence for us, we have a partner in LA Care, because we want to see you thrive. We want to see you do these innovative things like CRMC that take care of our patients, right? Because we are a Medicaid plan, and we do have a mission, and our mission is to find and help these people who need it the most. And even though it's a very cliche, I hate saying it sometimes, because sometimes you go around and a lot of people talk about why they went to pharmacy school, and some of it's probably bullshit about they want to help people, but some people it's real. Okay, and I want to say we want to live the mission, right? Because it wasn't just a topic. Back in the day when it was actually hard to get into pharmacy school, you had to interview and have a good story, right? You know what I'm talking about? Some of the old timers know it was, you had to sweat bullets because like you're at your pharmacy and you talk about that. And when you go to med school, you talk about the same thing. So, but when I want to say that we want to live the mission of actually helping people and of reaching out to those that are in need. And I think that's what the CRMC program does is specifically that. And when the results that we see, because we're reaching out to people that need it so desperately, and sometimes it's just impossible to reach them. I'm going to tell you something about okay, so like we have a really hard time reaching some members because of the fact that their addresses and phone numbers, for example, are just not updated. The amount of return mail I get, I have someone on staff that has to, you know, when the post office can deliver a mail, you know, it comes back to us and it becomes a stack of like bins full of return mail. That means that there's people that we can't reach no matter what. And the best person that can reach them many times is the pharmacist, because every Monday they're picking up the prescriptions in person. So that's why it's such an extra vital way where we reach out to some people who might be, you know, they might not have permanent housing, for example. It might be difficult, right? They're moving around a lot, right? So they might be homeless. There's many issues that people have, and it's not simple to define many times for a lot of people. And I think the CRMC program can help in that respect, in that you could reach out to some harder to reach populations that other people can. And I think that's the most important factor. And it's just another avenue that we can use, right? It's more than one thing that you can do to help people. And I think the pharmacy, right? We always talk about how like pharmacy are so accessible. And I think the CRMC program is what shows that pharmacies are accessible. So, and to the pharmacists that are here that have the independent pharmacies and that especially at my network, and you do have a partner, I will help. So let's do this together, right? To help as many people as possible and not be the cliche that which were by, you know, a lot of people pay lip service that we're going to help people, right? But you know, it's a lie, right? So let's do it for real. So you know now as I transition to my role, that's my promise to you is that we're gonna actually do this for real and try to help as many people as we can. And I'm hoping that we could use especially the independent pharmacists you know, well, because I see the value in it, and I see the value in all of you that are here.
Thanks, Alex. I always appreciate your real talk on the state of the way here. And again, congratulations on the one-seat promotion. Really excited to have you in charge. I don't know about you, but every time I hear Alex speak, I sort of marvel at the fact that a health plan leader is this supportive of advancing independent pharmacy practice. I think we shall be very grateful for that. Well, you know, they always say that behind every successful man is a very important woman. I can say that Alex has spoken, even before I met Connie, very, very highly of her. And we have the fortune of actually having her work with us. And although it didn't last as long as we had hoped, because she got this amazing opportunity to work for IHP, we're thrilled for her success and where she is now. And today she will talk about the state of IHP in regards to the relationship with California Right Collaborative. So let's welcome the other Dr. Thing. I do her justice, but let me just tell you that she's had, I swear, probably 7 different careers in pharmacy. You look like you're 20 still. So she's really experienced every element of pharmacy practice. And she really brings that, I think, to all of our meetings that you worked with us on, and I think to this role at IHP. So I think what a tremendous asset you are to the organization. So come on.
So good to see everyone here today. A lot of faces are so familiar because we work together through the California Right Collaborative. Today, like Steve said, I'm going to be speaking on behalf of IHP and our IHP team, who have been so supportive of working together with our IHP pharmacy sites So let me just start off by saying I'm representing here our pharmacy department that has been supporting this for a few years, including leadership, including Dr. Mike Blatt. We have Caroline Kim, we have Tim Liu, Sun Chung Vega, and Jennifer Yako, who are so like with each of the sites, and I'll list the sites in just a second, during, touch bases. They're always available, always working together, and you'll hear part of that sentiment in what I'm going to talk about today, just some of the examples of, I think part of the audience wants to hear, what has been accomplished in these health plans, particularly at IHP. You would just imagine it's really a big task to try to, make this go round and round, and it is. But how do you leverage the different partners to achieve that together is hopefully what I'll sprinkle in my time right now together. So in attendance here, we have some of our sites, which includes Graham, who will be speaking shortly, Desert Hospital Outpatient Pharmacy. We have Rain Cross, Parkview, Loma Linda University, Inland Pharmacies. So thank you so much for all your collaboration, not just today and yesterday, but just in all those different moments over this time. So we'll advance the slides unless I'm supposed to.
Yeah.
I'm supposed to. Got it.
The green button.
Okay, so today we hope to talk about, how we together have, how we can describe opportunities to achieve health plan goals through CRMC and to demonstrate the value of CRMC to us, IHP, and other health plans. California Right Meds Collaborative, today we've heard that, it stands for so much, right? But what sounded good to IHP leadership, even before I joined, that they came to the table, they had those discussions, and ultimately for the last few years have been continuing this mission. It's a lot of what you see in bold here, but particularly to together reduce the burden of chronic disease by advancing the role of pharmacists in the healthcare system. It's hard for any entity to do alone, and together it's been not easy, but easier. So what does the timeline look like? Right now is kind of where we have the start, but in the last couple of years, developing something like this within each health plan is different. For instance, IHP is different than LA Care, and IHP had to work together with CRMC. What are the different pharmacists? At the different sites within our organization to develop what does the workflow process look like? What is the payment structure going to look like? All of that, and I'll go into a little bit more detail about that, but ultimately you can get a sneak peek here that phase one, which has culminated, is kind of transitioning to phase two right now, included asthma and COPD.
Thank you.
That was by choice. And by the way, different than LA Care, which was heavily focused on A1C and diabetes. And here in phase two, now we're expanding our disease states to include others. So IHP, like I alluded to, we wanted to focus on improving asthma control. Particularly, we wanted to show a difference in the patient's ER visits and hospitalizations, and therefore reduce the total cost of care. At the earlier part, around 2020 to 2021, there were some data analysis of about 1 year's worth of data for about 153 patients. And from that initial analysis of our first cohort of patients, we were able to see that, yes, truly the aim that the company was after, what kept the administration up at night in terms of, inpatient visits and ED utilization, those did decrease. They did a 3-month analysis, but even in 6 months, they were able to see more, and it was continued. So great. So what was so great about the offer of this kind of model, working with patients by the pharmacist? It kept the member at the center, which IHP always values, and it was working with providers. It was doing those collaborative practice agreements. It included working with the different pharmacies at the different sites that needed help in the community. Within IHP, we have a lot of communication in the different departments happening, and we're really proud of that aspect that CRMC brings, because our patient needs a lot of help. As an example, transportation. As another example, case management, behavioral health. So CRMC is expanding as an example in behavioral health. You heard Steve mention that, but what can we do for our patients? For example, during COVID, when we recognize we have a visit with them and they need more support. They can't, we call them for follow-up visit. They can't come to us if it was an on-site meeting. All those things, we're able to connect the dots as much as possible to leverage our resources and make this a more robust program for our patients. Now, I want to go into a few of these bullet examples to connect the dots for us. So how did we manage to connect our resources in-house? How do we leverage our partners, for example, our different sites and the training that CRMC offers? You see here, collaborative practices mentioned in some of these. Graham at Desert Hospital Outpatient Pharmacy has been doing collaborative practice agreements and working under those, him and his staff, even before CRMC. So as a partner site, what great opportunity we have to have them lead that effort and share with us, bring the other sites fast forwarded in a way where we could kind of synergize together, learn from one another. And again, it always takes adaptability. So not one site's learnings and experiences is going to help. So we've always opened that table up to learn from one another. That's another example. Point of care COVID testing. So we've heard COVID mentioned as a maybe past tense thing, but during that time, it was so intense. Let's just remind each of us what it felt like. Wow, we're kind of in the middle of CRMC, we have patients enrolled, and all of a sudden we, physician offices can't get gotten a hold of. How do we, restructure things to take care of our members? And pharmacists, we all did such a great job, right? All of our sites really said, I'm going to do everything and anything to continue to take care of my patients. But that took a lot of discussion on what's the right way, what's the platform in which we're going to be able to contact our members and have visits instead of face-to-face visits, for example, Pivot. And I know at IHP, Bruno, you brought a lot of your expertise in leading the conversations around point of care COVID testing and vaccination workflow that was shared with the other sites. So again, the synergy has been great. The data has supported the onward motion of expansion. And we started with asthma intentionally. That was important to the administration, but happy to report that we are expanding to future disease states, which include diabetes, hypertension, heart failure, hyperlipidemia. So what other things are we hoping for with the expansion timeline? There are a lot of needs in our community. And for example, there are very rural areas that IHP wants to focus on. So CRMC seems like one of the programs that can really deliver on those kinds of pain points. With that, I will thank everyone and hope to talk to you later more.
Okay, so made the mistake of going up here without my introduction sheet, but I'm really excited now to continue this session on updates with the program and have Ramesh Vidyadarula from Desert Hospital Outpatient Pharmacy share the work that I've previewed now like several times for this partnership with CDO. Thank you. This partnership with CDPH and IHB and Cal Right Meds. I really love Ramesh's bio. I really have to read it because I think it's really good. Ramesh writes that he provides comprehensive and compassionate care dedicated to improving the quality of life for terminally ill cancer patients. His focus is palliative care with an emphasis on pain management. His approach is to be very accessible to his patients, helps reduce anxiety and improve outcomes. I think that really speaks well to the heart of this man. I've known you for so long now, and really is an exemplary community pharmacist in every way. That the depth and breadth of his clinical programs, I think it really blew me away to learn that you send pharmacists in the hospitals renowned, you send them into outpatient clinics. We have collaborative practice agreements with all sorts of different providers and programs. He brings 33 years of experience. You don't at all. 30 years of experience. The pharmacy practice, again, both inpatient and outpatient experiences. CEO for multiple pharmacies, really a innovator's innovator in outpatient pharmacy. So it's a pleasure to have you come up and talk about this important program today and share some of those pearls with our students. Thank you for being here. Let's welcome you.
Hello, everyone. Thank you so much for having me up here. I'm here just because all the training and the guidance that Dr. Stephen Chan and CRMC has provided me, so I could get off the ground and be able to do exactly what he taught us to do. My name is Ramesh Upadhyaya. I'm a Director of Pharmacy Services at Desert Hospital Outpatient Pharmacy in Desert Regional Medical Center in Palm Springs, California. Today, I'm here to present our CLM pilot program for post-stroke management. Before we go on to discuss the nuts and bolts of our CLM program, I would like to give a shout out to the leadership. The leadership for its vision, collaboration, and coordination efforts it took to create this pilot program involving mega players. There's California Department of Public Health, California Readiness Coalition, obviously, Inland Empire Health Plan, Visión y Compromiso, Desert Regional Medical Center, and finally, the team of us. So the catalyst for this entire effort is Dr. Chan and his elite team over right here. Amazing, amazing team. Along with Dr. Jessica Nunez de Ibarra of CDPH. You know, they all deserve a big round of applause. Now, I have no financial disclosures. So now we divided our presentation today with an outline detailing a pilot site, our post-stroke hypertension management pilot design, the quality of clinical services, and CRMC collaboration efforts. Now, the success of the pilot sites depends on various factors. As we talked to some of them before, the vision, the collaboration, the coordination, and implementation. But along with that, what's required is the willing sites, the willing CMM pilot site, and that was us, the outpatient pharmacy, and our hospital, the Desert Regional Medical Center. Any reservations from either one of us, we would not have been here to speak up on this pilot today. Now, to further bolster our qualifications for the pilot sites, we had the departments that fit like a puzzle for this pilot. So we have transitions of care team that rounds with the physicians in the hospital, helps discharge the patients, do reconciliations, bridge gaps in care, quality, the cost analysis and stuff like that, to make sure the patient goes home. And we have outpatient pharmacy that helps coordinate beds program. And also our CMM and clinical residency staff with very talented clinical pharmacists and residents to complete their comprehensive medication management post-discharge. As you see, our care model addresses to bridge gaps in care, starting with the cancer care, which includes hospital rounding against physicians, helping with med reconciliations, med stability logistics, post-discharge follow-up to help prevent readmission. Our post-discharge program includes comprehensive medication management, adjusting therapies using collaborative agreements with all the local physicians,
I can
compliance
can I
coordination,
switch to this computer?
and remote patient monitoring.
No.
No, okay, so she'll have to share.
This is our team, by the way. And this is our team of talented clinical pharmacists and residents who champion the process. I do need to acknowledge countless hours our happy students from various schools, both in Southern and Northern California, spent behind the scenes to make this program a success. Our affiliations, over years, we have gained many clinical affiliations, especially with our hospital, Desert Regional Medical Center, and our family medicine team, which is Desert Physicians Medical Group, and Desert Heart Rhythm Consultants, our cardiology group, our High Desert Medical Center. It's ever expanding clinical affiliations that we have. Along with that, our other affiliations include our remote patient monitoring partners like Goji. And we are looking to partner with other RPM sites as well, RPM programs as well. Various schools of pharmacies, pharmacy organizations, and also professional networks such as CRMC. Our post-stroke objective for our post-stroke hypertension management is to improve post-stroke hypertension management using team-based care approach and a comprehensive medication management. We discussed in our previous slides about transitions of care and comprehensive medication management. And another important team member to our group that we added on is community health worker. Community health worker who can provide advocacy, health promotion, assistance that these patients need post-discharge due to all the complexities of post-stroke is the biggest gap for us. Now, among the pilot programs, many measurable factors. Our outcomes include a 30-day percentage mortality rate and 30-day percentage readmission rate, 30-day percentage hypertension control, and 30-day percentage of patients on anticoagulant, with patients who have AFib and are AFib, and also 30-day percentage of patients who are antithrombotic therapy in 30 days.
First slides on here.
These outcomes are based on the measurable factors within get to the guidelines. Registry tool from the
share them,
consultation.
Well, if they're on here, just stay on.
Now,
and then
these are all the
we'll-
collaborations that.
She can advance them on that, and then we'll just.
Now, if you look at this workflow map that we have created, it's not something that
she
we have
updated
done, but it is
this slide deck.
all of us together.
It's what I,
Well, she
I mean,
did.
she updated it.
It's all the organizations that are involved in creating this pilot have to go through, each one of them have to go through their IRBs to make sure it's an acceptable format. This complex workflow was designed. This complex chart was designed, developed, so each loop is closed and handed off to the next team. So the patient would experience 100% of the care and best outcomes. The fruit of all the organizations working together, I will discuss some basic workflows, and just so you can see how it works, just a simplified version of it. First, as a patient, we do an EMR search of the hospital records to search for any stroke patients, and we screen the patients for pilot worthiness. That means they have to meet the qualification to be on the pilot. And each qualifying patient then receives Med-to-Beds program. We have Med-to-Beds program for the entire hospital, but these particular patients, they receive Med-to-Beds And also they receive an introduction to the pilot program. The patient is then contacted by our transitions of care pharmacists every week for assessment. Now, if you find any need or any appropriate opportunities, then the patient is referred over to our ambulatory care team and or community health work team to help intervene and promote positive health outcomes. Then finally, we conduct a review, we review the outcomes on a periodic basis and measure them to see what the outcomes were.
I could save them.
Now,
I could save the presentation. Loaded here.
the
I could
complexity
save the
of
presentation
stroke
and then
patients,
load it here.
there are many possible issues,
Is that
comorbid
right?
diseases, functional deficits that increase the complexity of stroke patients. Some of these include economic instability, lack of social support, limited access to care, poor literacy, and poor psychosocial coping skills. So because of that, our pharmacists have to slide into, our team has to slide into some specialized roles. Of course, there are transitions of care, pharmacists who performs med reconciliations, meds to beds, logistics, affordability, and appropriateness, interventions, and finally the follow-ups. Our community health workers, they assess the patients for their healthcare access. Sometimes working with the patients, just as simple as getting appointments, medical appointments for them, or arranging a transportation. So for those who don't have it, arrange for some local resources, addressing social determinants, health promotion, coaching, self-management, health navigation, teaching to navigate healthcare. Sometimes what these things seem like a very simple task. Post-stroke patients, especially who don't have a health at home, can be very daunting.
So I would just end the
And
exciting.
at the time, this little help that we give them
After
can
these
bring our
hours, I'll out of here and then.
No, just minimize this
comprehensive
You take
medication
this slide
services, another critical
and
service that
minimize
our
that and
pharmacists provide.
and maximize Zoom.
They assume to kind of try to keep the patient at home
Change.
by
anything.
prioritizing their
Thanks.
problems,
You
help patients get to help
Well, we got
their
it.
health goals,
Put her.
improve medication compliance by addressing safety, efficacy, and adherence. Optimize outcomes, helping the patients meet the clinical and personal goals. Monitor the routinely follow up and monitor and reassess. This is my favorite slide, is because all this program can be successful only when it's sustainable. And that's where this whole program of working, the program that trailblazing that Dr. Chen has done, creating the CRMC program and collaborations with IHP and LA Care, and who believe in his efforts and provide the assessments to the model. Without that, these programs will not survive. And the fruit that we are enjoying today, or will be enjoying for many years to come, is the advanced practice opportunities for all our pharmacists. We would like to highlight how CRMC has developed has helped us to create a sustainable outpatient clinical pharmacy program. And of the many opportunities provided by CRMC, here we have been that have been very critical to supporting clinical programs at our site. CRMC worked very closely with us, with the health plans, to secure reimbursement for clinical services, provided support, especially when I first started. I used to pick up the phone and call, and Chan said, Chan, I see my first patient, what do I do? How do I do? And he was all there to always there to help with support. Sometimes, I would call up and say, I'm starting my clinic, what do I have to do? And what are the things that are needed in the clinic? And our first collaborative practice agreement, Dr. Chen would say, he'll give a format and say, this is how the collaborative profession agreement should be, and go speak to your physician. And he was willing to come and talk to the physicians, and as a matter of fact, he did come out and speak to some of our medical groups to talk about the opportunities about setting up the CMM practices at the locations. I mean, incredible support. Training, this is what it is. I mean, we get an ongoing evidence-based clinical support and training, and networking and collaboration, creating networking and collaborations for continued expansion of the services. Thank you so much. Do we have that?
Yes, we do.
All right. Okay, just minimize
I
it.
have, so we did have,
Real?
our clinical pharmacist and also our research director, Natalie
That's
Valdes,
hers.
who's going to join us by Zoom to kind of provide some of the data metrics of the pilot that we are currently
Still
on
see
right now.
him,
Also,
so
Natalie, you could share.
we might have to.
Oh,
stop.
she's sharing her screen now.
Hi, everyone. Thank you so much. Good morning.
Oh, no, we
My
can't
name is
hear her.
Natalie Valdez.
Close the-
Are you able to hear me okay?
minimize this.
Wonderful. I'm sorry I could not be there with you today in person. But I'm honored to share with you a
Hey,
patient case example and continuous quality improvement effort for the pilot program.
just have to find it again.
Natalie, we're trying to get your slides up.
Wonderful, no problem.
Okay, you're good to go.
Thank you. I'm just going to stop sharing video just for the bandwidth. Thank you so much. Can everyone see my slides now?
Yes.
Perfect. Thank you. I have no disclosures to disclose. So we officially launched the pilot program in February, in which we started to see patients for post-stroke hypertension management. Being early in the pilot, we don't have data to present today, but we would like to go over a patient case with you. For the sake of time, I will briefly summarize the main points, and the case is actually from a patient in our post-stroke hypertension management pilot. The case is involving our patient R.A., who is a 57-year-old Hispanic male, and he's recently been hospitalized for hemorrhagic stroke. And he's being seen on April 1st via telehealth by our PGY1 resident pharmacist, John Lee. We spoke with the patient's wife, who is involved in the patient's care, and she confirms that since the patient's been discharged from the hospital, the patient has been adherent to his blood pressure regimen, and he's also been checking his blood pressure about 3 to 4 times a day, with the average blood pressure reading from the patient's blood pressure machine at 127/83. And the patient currently has a few pending appointments with primary care, physical therapy, and neurology. When asked about cholesterol medication, the patient's wife recalls that a long time ago, the patient was taking pravastatin, but they're unaware why it had been discontinued. I'll briefly discuss the patient's history of present illness. So about 2 months ago, the patient awoke with left-sided weakness, slumping over while trying to get out of bed. His wife called 911, and the patient was airlifted to Desert Regional Medical Center, where he was diagnosed to have had a hemorrhagic stroke. He would stay admitted for over a month, and this hospital stay would be notable for difficult blood pressure control. A month later, on March 7th, the patient was deemed stable for discharge from Desert Regional Medical Center to Desert Regional Medical Center's inpatient rehabilitation. He would stay there for an additional 3 weeks. The patient had several blood pressure medications after his month-long hospitalization, which was notable for difficult blood pressure control. So for the sake of time, I won't read off all 14 medications, but I will say that this is a typical amount of medications we've been seeing in patients that had a stroke. And sometimes there's even more medications on board, especially for comorbidities such as diabetes. Sadly, the patient did have a history of MI, which happened about 9 years ago. And right up to the stroke, he had been struggling to control his blood pressure. He also was not on a statin medication for secondary prevention of ASCVD, and his LDL was elevated at 113. Family history also revealed that the patient's father had diabetes and hypertension, and the patient's father had also previously suffered from a stroke. The patient lived with his wife and his 2 children, and he owned a company where he worked prior to the stroke. Tragically, the stroke impacted the patient's ability to work since February, but he's been making a great deal of progress in terms of his recovery and is now back home with his wife and children, working on physical therapy and improving functional deficits from his stroke. Our recommendations to the patient, seeing as his blood pressure had been difficult to control over his month-long hospital stay and now is at goal for the most part, we decided to continue his blood pressure regimen. So after a few cardiac events, the patient was still not in the care of a cardiologist. So that was one of the other recommendations we had, was to recommend for a cardiology referral. Additionally, we felt that it was important to add a high-intensity statin for secondary prevention of ASCVD. And our team continues to follow up with the patient on a weekly basis, and he's been doing well so far, continues to be adherent to his medication while also checking his blood pressure throughout the day. And so I just wanted to highlight the importance of making continuous quality improvement changes. So while we try our best to design a workflow that is perfect and will have the most impact on improving patient outcomes, there are still ways that we can improve and make processes just much more efficient and yield better results. So one example of a small test of change that we implemented was to improve the way that we screen for referrals to a community health worker. So in other words, we wanted a consistent way to screen each patient for the needs that a community health worker may be able to assist with. So we decided to implement a screening form that could be used by our transitions of care team during their weekly follow-up calls with patients. And we decided to pick 6 patients that were already seen for their first visit. And we had already attempted to screen them to see if we needed to refer them to a community health worker. So this would be patients that are pending their second visit for post-stroke hypertension management. In this group of 6 patients, after their first visits, only 2 were evaluated to need a community health worker to intervene. But after we used the screening form on the second visit, we were able to get 1 additional referral to community health work. So we went from 2 to 3, so that's about an increase in 50% referrals to the community health worker just by using our screening form. And the reason I'm sharing this with you today is that the patient that I just presented on happened to be that patient that we referred to the community health worker using the screening form. He is that extra patient. And so he received additional care and support that we may have overlooked, the need for him to receive this care and support if we had not implemented the screening form in our process. That's why it's very important to continuously look at our internal process and make sure that we're continuously trying to improve quality. And in conclusion, I would just like to thank CRMC and all the organizations that have come together to create the post-stroke hypertension management pilot. And thank you for your time today. We have enjoyed the opportunity to share this wonderful pilot and collaboration.
So for our next session, we're having a return speaker, someone who those of you within our collaborative know quite well, Dr. Drew Wayne. She has spoken to us several times about patient engagement, both motivational interviewing and shared decision making. And just to recap, the reason this has come up is because the more you get involved in CMM and working with these very complex patients, especially remotely, and especially in a circumstance where you're not integrated as part of physician practice. Getting patients engaged to enroll them and then retain them is a huge challenge. We recognize that fully. So we're going to have a couple of approaches to helping to figure out how to best work with these patients. And a lot of it's going to require your engagement during these sessions. So Dr. Wayne will talk about the tools that you can utilize or consider in engaging those patients. And then after that, we'll have our remote team and LA Care talk about actual ideas and best practices for connecting with patients remotely. For background, Dr. Wayne is a senior, senior clinical sciences director for USC School of Pharmacy, Commercial and Development. She's a USC School of Pharmacy graduate, having done 2 residencies, one in general pharmacy practice and the other in psychiatry. We actually both worked together down at Skid Row, serving patients at the Center for Community Health. After graduating, she joined Alameda County as their lead psychiatric clinical pharmacist, was there for about 5 years, and then transitioned over to Otsuka, where she's had a steady rise in promotions and opportunities within her company. And I think really importantly is I've known Adri for a long time. She has a very, very strong passion for helping underserved populations, obviously with the mental health space. And is really great at looking and finding opportunities that align between the work that we are doing and mental health and other related conditions. In fact, she identified the opportunity to bring David Dadimov on our faculty through a $1.26 billion whole person care program with LA County, and he's still with us today. He's fantastic. So again, really appreciate her partnership, her expertise, and please welcome Dr. Drew Wayne.
Have the unenviable task of, this is like the presentation and then we have lunch coming up. So I know that we'll do a hard stop at 12:25 so you can eat lunch. But basically this is a shared discussion to be able to share best practices of what are you doing when you're talking to patients over the phone to recruit them to either come into the pharmacy for comprehensive medication management of their chronic disease state, or if you're actually setting up subsequent appointments over the phone. So what we'll talk about over the next hour and actively discuss is basically we're going to mark and kind of determine what are the ingredients for successful patient engagement. As a full disclosure, I am an employee of USC Pharmaceutical Development and Commercializations. The views expressed in this presentation are my own and not necessarily the views or opinions of my employer or any of its affiliates. So thank you so much for those who filled out the survey results, because there are different questions we wanted to ask in terms of how is the CRMC, CMM programs or MTM programs working out for your particular pharmacies? And we asked a series of about 6 to 7 questions to try to figure out what is working, what is not working, what are the remaining challenges out there that you're dealing with, and hope to prepare us for the session today, so we can go ahead and discuss some of those best practices and share among ourselves. So I also spoken with Janice Cooper over the phone. Hi, Janice. Thank you so much for helping me get a better understanding of what the kind of the day-to-day challenges that you encounter when you're speaking to many of these patients over the phone. So the first question that we asked was this question: from the patients that you see, what you have successfully from the patients that you have successfully contacted, what percentage of patients were you able to recruit for CRMC enrollment? And we actually received a large range in the answers, anywhere from 10 to 80%. Most were actually in the 10 to 25% range. There were 2 respondents who actually said that they were able to recruit 80% into the CRMC and to go ahead and enroll them. If those two respondents are here today, or if you're close to that top of the range, 70, 60 to 80%, the pharmacies that are able to recruit, let's have a little bit of discussion. What do you think are the key ingredients? Like, what are you saying that have successfully engaged the patients that they want to continue the conversation with you, and either they want to continue with the next appointment or they want to come in live or
A microphone that I can.
Yeah.
so let me see with the show of hands, and you can just go ahead and share. Maybe the microphone is going to go around.
You need some answers. This is interactive.
I think like a smaller room would work better.
Yeah,
Yeah.
I'm gonna go this direction. These guys are very extroverted. So. How about this team? Anyone over here? Let me share.
Some people are squirming, looking down, moving away from Steve.
This is not to share, but to ask a question.
Yeah.
Wanted to see what are the strategies to recruit them into the CRMC while we're on this topic. Can you share some best practices on how can we talk to them and convince them?
That's exactly what this session is about. We wanted to kind of get input because some of us have been very successful. For those two respondents that's able to engage and recruit 80%, that's an astounding statistics. And we want to learn and kind of like mark down what the best ingredients are. What I can do, and I will go over later, is kind of like simple strategies and motivational interviewing, what you can take home with you. But, oh, Steve?
Sorry, I didn't interrupt you, but I was gonna offer you an answer.
Yeah, go ahead.
Obviously, I'm not a CRMC pharmacy, but I've run programs where I've cold called people across the nation to enroll them into basically management programs. And so if you were to ask me the question, what are the biggest selling points that I use? First of all, I leverage the trusted and recognizable entity. So in my case, I leverage the fact that I work at USC. And so by using the USC name, I think it immediately provided some level of comfort that I've heard of it, that kind of really are, number one. Number two, I focused on value. Okay, so here I am trying to solicit a service with them. They don't know who I am, right? They don't have any confidence necessarily in what I'm offering. But what I zero in on are the things that they could understand. So for example, if I'm working on asthma, what I tell them is, because you were selected to be part of this program, there's about $100 worth of equipment that will help to optimize your care. You can get that for you for free by having it. So how's that sound to you? Things like that, which are half yes and half not. At the end of the day, I think if you can get them to appreciate that there's high value in what you're offering, I think it's an effective way to accomplish.
I don't think it's half BS at all. So I wanted to actually thank you, Dr. Chen, for sharing that. Obviously, we both worked in a clinic together in the middle of Skid Row. As you can imagine, there's a lot of inertia and learned helplessness within the kind of population that we did treat at that time. So it was very difficult to motivate them to even come in for appointments because they've perhaps that had past experiences and encountered in the past that they, that made them kind of a little bit jaded. So let me add to you, I kind of don't want to share my experiences yet and kind of some of my tips before I hear from the group here. So I'm going to take just one last, is there anyone willing to share? Okay, Shushma, thank you.
Okay, so I'm nowhere near 80%, but really having the right team that can engage with the patient, the language barriers, obviously, overcoming that. We actually got our technician trained. So when the patient is enrolling, there is a compassionate kind of sitting down with them and talking to them, bringing them in is the first priority. And then visiting them to the first visit, if they unfamiliar with the site, at least offer to go to their house, and I've done that in the past, and really talk to them. So that really.
Nobody
builds
said
the
anything to
engagement of the
me.
patient. So when we're talking about the patient engagement, that's how we go. So we
You want me to
started.
text somebody?
With 1 or 2, but having the
See if I can
team
find out.
and the pharmacist,
thanks,
the right
Rita.
person, and also the technician. So the training that the technicians got was really, really important for our site, especially the language barriers. And then the other thing I would say is engaging the physician. So I reached out to NA Care, and they actually had a conference call with the provider. And really sharing that information was very critical, the program, the benefits. So now we have 30 patients enrolled at our site, but it's taken a long time. But it's just engaging the team, making sure that everybody's on the right page, and especially getting the providers to understand the benefits of this program.
Okay, thank you so much for sharing that. So what I'm hearing from Sushma is a couple of things. On the logistics side, she has a physician champion who's from the provider side, she has the provider engagement. And then on the technician or pharmacist side, she's able to have someone that can readily identify with the culture of the neighborhood and help with the language barrier. And the second thing I'm hearing is that you're also able to compassion, like what you're saying, is have that person speak in a way that shows care for the individual's best interest, the patient's best interest. That was the second thing that I heard. The third thing that I heard is when the technician offers to go to their home, that's a logistical point of convenience, right? So if you have on the logistics side, kind of like you make a spreadsheet, okay, if you have physician champion, a provider that supports your work, and the second way is if you're able to offer something of convenience so the patient can continue engaging with you. And then on the pharmacist / technician side, if you're able to be literally competent and kind of know the patient's culture, the area's culture, how to work with the patient, overcome the language barrier. Secondly, speak to them in a compassionate way, and then also offer them convenience. So that's what I'm hearing. Anyone else want to share? So what I'll do is I'll quickly move on. So the second question is, what strategies do you utilize at first appointment to secure the patient's engagement? When do you start talking to them about the goals of the treatment? And we did get a slew of answers and kind of responses, but I just picked out 3 or 4 so we can process these 3 or 4. We offer to help them improve their asthma and COPD symptoms free of cost. We're able to engage patients by stating we are like a health coach and liaison to their provider. The second response, motivational interviewing most times begin with session with small talk to see if we can find a common interest to break the ice. The third response, I use the strategies learned from CRMC, such as emphasizing shared decision-making and the importance of managing diabetes. I share the current A1C as a reference point for us to set a goal. It does take a long time during the first appointment for the intake. However, I use their responses by the end of the convo to provide education, goals, and treatment plan. And then lastly, talking about the program and asking their goals. What are you seeing? Let's take the first quote there. What are some of the potential barriers when you say something is, or kind of like the pros and cons? Is it good to be able to share that this program is free of cost? There's no right or wrong answer, depending on your patient population. Is that a good thing? Would that compel them to want to engage with you further to take advantage of the services? Do they see it as a benefit, or do they see it as kind of like free and they're kind of a little suspicious of it?
Maybe have them vote. How many say free is a good idea to run the program up front? Okay. How many say it may not work as well? Okay, interesting.
And for those who says it may not work, I'm interested in hearing, what are your thoughts? Why do you think it may not work?
I would think that it would work because if you get stuff for free, you don't appreciate it. I think stating that it may not cost anything to you, but it does have a cost involved. It lets them know like, okay, I'm not gonna be financially responsible for it, but it is something of value.
And this is like Steve and I actually had discussion revolving around this because I actually was just really curious on my own. In some patient population, let's say you're serving the underprivileged group, right? Cost is very important to them. So if you're explaining that this is a free program of no cost to them, I would think that they would want to access it because they would see it as a burden off of their shoulders and they would see it as a benefit that they want to tap into. But let me share a different perspective. So, and I wanted to hear a little bit from you before I shared my experience. So, as you know, I'm board certified psychiatric pharmacist. As a clinician, prior to my industry experience, I was used to talking to patients who suffer from a variety of mental illness. I had patients that I speak with that were hearing voices at the same time, and they're trying to engage with me and answer me, but at the same time trying to quiet the voices that they're hearing. I dealt with a variety of patients with mental health conditions, but prior to actually entering pharmacy school, I was in sales for 5 years. And I sold the type of product that was probably the most difficult to sell. And that's in the area of education things. So if you've ever seen the TV commercials, I teach in tech or DeVry, trade schools. So motivating kind of students to be able to engage in this 2-year short trade school program and kind of enrolling them and keeping them motivated throughout the whole length of time. That was kind of what I did. So I didn't work in any of the trade schools that I mentioned. But what I did was my title at the time was an admissions representative, but in actuality, I was actually a salesperson. I did a lot of cold calling over the phone to try to bring them in. And what they did was they tracked our success in various measurements. One, how successful are you at getting the patients in through the door after you call them for an appointment? And once you secure the appointment, what's the percentage of those students that you're able to enroll into the program? And then the third thing that we were tracked on, if you did enroll into the program, what's the percentage of students that actually started school and stayed in school for at least 6 months? We were tracked just very systematically, very rigid in those specific, it was hard, cold percentages. And much of our compensations depended on that. So I would say, I don't know, on a scale of 1 to 10, maybe I would rate myself an 8 on the scale of cold calling expertise. And there were kind of a couple of things that we did employ to solicit curiosity and to get them want to participate or at least want to come through the door. And one of the tricks, or not tricks, one of the things that we used was that we made the program seemed exclusive because it's human nature to want to be a part of something exclusive, to be a privileged few, to have like an elite status, to get into a program that not anybody could just get into, right? So I'm wondering, what would the patients think if you say something like what Steve had just said? We provide, instead of free glucometer, say this particular glucometer retails for $500, but your insurance plan covers it within the context of the service that we provide. Like, what if you said something like that? Would that be more effective? Would that not be more effective? Like, I'm interested in hearing from you. And then also, what if you said something like, instead of I'm calling from CRMC or X entity pharmacy and saying this is a free service, a free program to you. What if you said something like, this is a valuable program that your insurance company pays for. You can choose either to take advantage of it or to not take advantage of it. So you're giving them free rein and complete autonomy to whether to enroll or not to enroll in your program. But at the same time, they know this is a valuable service that is already paid for by their health insurance. Would that work better? I don't know. I don't call as part of the MTM group within CRMC. It was a different context that I practiced in, so it may not be readily translatable, which is why I want to make this more of a discussion.
Yeah, that was great. I love the comment. So another byline that I've used, that you just asked me, is, I'll say something like, the Kaiser health system does really well in terms of improving heart disease, and one of their secret ingredients is this service, which is exclusive to their population. And I serve my senior family Beverly Hills patients with this service, and this is really available to you. That's paid by our plan. So basically, like you said, painting a picture that this is a pretty exclusive, very high impact program that we're bringing to you because somebody else is paying for it, not for
Feedback, Ramesh?
I think whenever you say something is free, people suddenly become their defenses are up, they're more skeptical. They think that there's something attached to it that they have to give back. But if you kind of be upfront and say, hey, this service is covered by your insurance, and that it's a very valuable service for your health or whatever, then they're more apt to come forward without any hesitation, without any they know that and they won't be attached to it.
And if you want to,
It's in their interest. I think just saying coming up and saying, oh, the service is free, then they want to really. Sometimes they're very hesitant.
That's interesting. So that's true. Now that I think about it, some people, when you say that this is free, they think like, oh, I'm gonna have to pay for it down the line. But there's rarely any free thing on this earth without some sort of strings attached on the back end. It's almost like what is it? Like a timeshare presentation. Like, yeah, you can do a 3-hour timeshare presentation, but we're gonna hunt you down after this program to try to get a timeshare with us.
Yeah, that's what I was gonna say that. Actually, when you say it's free, there's something just clicks, like, well, it's free now, that's what they are, what am I gonna change later?
Yeah.
And that's what we're.
I know, she told me that.
I wanted to say that, the motivational interviewing,
Are you
to break the
fine?
ice cream,
Whatever's on.
I think that's kind of the
Fine.
probably use more, because it's less spelling at first. And then you identify if they agree, they're having trouble breathing, or they've got better diabetes.
Are you cool with eating whatever's over here instead of going on no penalty, or
100%.
which way do you want
And
to do it?
you know, class to something
That'd be fine with me if
and
they
so
want
if
to
you want to
feed us.
definitely go over it. Right?
Okay.
But I will highlight some of those key things that you can implement quickly that perhaps you can use as tools to make your engagement and phone calls more effective. The third question that was asked, what are your top 3 challenges in recruiting patients? And these are some of the responses. The first question is how I got their information. They're very skeptical about the call. Very naive. 1, unless it's a warm transfer, it's a challenge to gain patients' trust in a cold call to recruit. Patients may not have time to engage and commit to an appointment. And 3, patients refuse because they prefer to follow up with their doctors or clinics. Lastly, patients do not feel that it's necessary. They live far from the pharmacy. They don't have transportation. So let me ask you, for those of you that have effectively dealt with part of the issues spelled out here, maybe some of it, maybe all of it, you don't have the same issues as what's listed here. What are your key ingredients for success?
Hi, We don't, currently, my organization, we're not a part of CRMC as of yet. But I could have a little bit of tidbits about how we participate in other like outcomes.
We get done at 5, it'll be 5 meal penalties.
One
5 hours.
One key part about having people, the challenge that people have is just unfamiliarity with.
It's just 1 hour regular time.
So,
Plus the hour you're working.
And the source that has very high success rates.
Yeah. You just put it on your sheet as a meal penalty, so you would have 5 meal penalties.
And the patients and all the staff.
MPs.
And those,
And for each
and
one
as
of them,
we
they
are
give you
delegating
1
the
hour
work
regular
to,
time.
let's say, as
3:30,
with pharmacy students or things that they may not be familiar with.
3
The
o'clock.
patients who answer the calls may think it's like a scam.
So that's
special.
just follow your
these days. So,
Yeah.
I think.
It'll be, if we get off at
having
5,
that
it'll
initial,
be 8 and 2.
relationship building.
Plus
with,
5 meal
with your teams. To the patients over, it's not overnight, right? It's just.
1 hour.
Many years when the patients already know your staff and just
But you
when you're
just
calling
put,
the patients and it's
on
not
the
just
sheet, you just put
making it seem like you're
5
trying to sell them
MP.
something, but it's starting out having a good conversation.
And then your hours,
Hey, you know,
regular
how
hours.
the kids and things like conversation like that. They're then open up to more further discussion on their healthcare.
Thank you. Thanks for sharing.
Oh, sorry. We are with Rayleigh's Pharmacies, so we are a grocery chain pharmacy in Northern California.
Oh, okay, great.
And my name is Simon. I'm one of the pharmacy supervisors, and here I'm with our director, Cindy Pong.
Oh, thank you.
Let's make it a habit to introduce yourself.
Yeah.
I'm sorry to pick on you. But part of it, I just want to make an observation. Rayleigh's is a dominant university of Cal. So when you drop the name Rayleigh's, I think there's some level of trust and familiarity, right? So I think that actually plays into a tool that you can use to help student patients.
Yeah.
Hi, my name is Bati from Loma Linda. So I'm also not a CRMC pharmacist, but my experience with cold calling some patients is kind of a mix of 0.3 on that slide and something you said earlier about gaining patient trust. And the lady next to me said about having a champion provider is when I use something like a post-discharge MedRec and I'm kind of cold calling them like, oh, you want to do this? They're just kind of like, oh, what's the point of this? Who are you? But on other cold calls, like when I'm checking their adherence for certain medications, and I say something along the lines of, I'm calling on behalf of Dr. Blank, you have to pick up this medication. They're just like, oh, you're fine from my doctor's office, you know, and then they're much more willing to have a conversation with me.
Yeah.
So, yeah, it just depends on how you can like connect with the patient. I don't know.
Absolutely. So what I'm hearing is if the patient hears over the phone that you're working with someone that they already know and they're a trusted healthcare provider, which is their primary care physician, then that opens up the doors. And I would imagine, put yourself in the patient's position. If you get a random call from somebody, but they mention your primary care physician and that person's working with the primary care physician, right away that opens up the lines of communication. Whereas sometimes you might be spinning your wheels. I understand when I spoke with Janice over the phone, sometimes it seems like your institution that you can do that, but and name drop the PCP's names. But at other times you're given a long list where you don't know who their PCP are, and you can't name drop the PCP. So in which case, what do you do about that? Like I would imagine many of these responses came from the responses are the way they are because you're unable to do that, right? So let's brainstorm on different ways that we can do that. Like what Steve mentioned earlier, what if you said USC? What if you're saying you're working within this program? What if you're simply saying that you're working with their health insurance and then name their health insurance? Would that work?
Hi, I have to get my thought. Good afternoon, everyone. My name is Whitney, and I'm a clinical pharmacist working at Pico Care Pharmacy located in Rivera, California. In terms of some of the challenges that I think that we could address is just addressing their concern in the first place, like, oh, I understand that you prefer to follow with your doctor, and then also offer a unique opportunity to them. So, oh, we can talk to your doctor directly, so that way you can converse about certain, concerns that you had and things like that. And then also asking them for their feedback as well. I think that, in the work that I've done so far, it's been very, very helpful when I ask them for input, like, what are your thoughts on doing this? What are your thoughts on doing that? Because it allows them to use that free will and actually buy into what you're doing. So that's how I've kind of like navigated, especially when I don't know their PCP, or like you mentioned before, name dropping their health plan and saying, hey, your health plan has told us that you are, you're eligible for this unique service that we're providing for you. How would you like to schedule a time, or what do you think about scheduling a time at this day and this day instead of, something like that. And of course, things that I've learned like in schooling is making sure that you, I guess, give them the chance to make a decision instead of just a yes or no response. So,
Absolutely. So, what was your name again?
my name is Whitney.
Whitney, yes. So what Whitney says is, it is 100% in alignment with the spirits of motivational interviewing, which is respecting the other person's free will and their autonomy, engaging them, not falling into the expert trap, and basically you're there as a role to guide them through the process as opposed to kind of like force them into certain.
Hi, my name is Parth, also from Pico Rivera. Question to the team is, I know these days, a lot of communication is digital. There are a lot of apps. Could we maybe partner up with our respective clients and maybe even have an app where we can call through so that their caller ID would show like an LA care number or IHP number? This way we might be able to get a little bit more credibility, or like IHP CRMC program, something of that sort. This way we might be able to get a little bit more credibility when we're talking to them. But the hardest part is the first few minutes. After that, as long as they're conversating with us, we were able to kind of conversate with them, but it's the first initial discussion.
What do you guys think? I think that's a great idea. Ramesh? Tony?
I didn't hear, I'm sorry.
The caller ID?
Well, I don't know about the caller ID, but I can give you some examples of what has worked for us. Yeah. So my name is Tony, so I'm the CEO of Diabetes Care Partners. Your diabetes education for health plans. One of the things that I noticed, and it's kind of going to your point, is that you kind of need a introduction. And the introduction is really important. So whether it's an introduction from a physician or an introduction from a health plan. And the one thing that we just started with a health plan was a letter of introduction. So, I think for this to really work, you need everybody involved, working on the same level, the same team. And the health plan is willing to send out letters with your name on it. So they get it in their mailbox. And the problem is, again, I think it was mentioned that a lot of people are transient, they're not always in place. And that would be a problem with caller ID as well, because if you have a long number, we go through a lot of numbers. And a lot of them, or the funny thing is, they're on prepaid. So prepaid, we might not be able to afford for 1 month, but the next month, we're putting money on it, so now it's working. So automatically you're thinking, oh, well, that number is disconnected. No, it's not. You just needed to wait another month, and it would have been connected, right? So these are the things that we deal with in underserved all the time. So this letter of introduction, I think, is a really interesting model because it gives them an idea that, okay, well, there's a program, number one. Number two, well, there's pharmacies or programs out there that I could either enroll into or I can call
And the first thing you would say is, this is coming from diabetes care partners. Did you get that letter from Elder Care? Or something, right? And if they say, oh, yeah, I got that. Well, that's us. And let's start the conversation. And one of the things I would say in that conversation is do not talk about features about your programs. Meaning that it's 6 weeks long, or it's 1 year long, or anything like that. Don't talk about features, talk about benefits. What are they going to get out of it? Because that is the key to getting them motivated, right? To give you a good example, one of the things you would say is, our program is something a lot of people really understand so that they can love it. Is there something that you miss right now that you haven't eaten for a while, or feel guilty about when you eat, when you have diabetes? Well, we get patients all the time that feel that exact same thing. And after the program, they don't feel that way. And plus they have better control diabetes, right? So it's a benefit more than a feature. The more feature you put on, the less and less and less and less they're going to feel like you're.
So true. Thank you for sharing that. I would sign on if someone called me and said, Sarah, you miss all my food.
Yeah, thank you. I just, by the way, I didn't introduce myself earlier. So my name is Sushma Patel. I am a pharmacist in the prescription shop in Montebello, very close to Pico Rivera. So one of the things I really like Khan's idea about the app, but having listened to Tony, but what LA Care does a really nice job is that they actually introduce the patient initially. So LA Care personnel actually calls first. They introduce the patient to us and through a three-way call. So that's been really, really instrumental, just so you know. So I know most of the plans does that, so that there is a barrier that's broken right now.
Yeah, no, and that is the absolute best case scenario. And when I spoke with Janice, she told me the same thing. It's like LA Care will do warm transfer. So recently I did hear that because there's just so many people to call and they can't do warm transfers all the time. Recently, some of the pharmacies have been receiving cold call lists. So to call concurrently and then working together with the warm transfers. Of course, best case scenario is warm transfer. Second, Tony's what he suggested about getting letters from LA Care, so you're not an unknown entity. That's the best thing. But one thing to keep in mind, if you don't have the ideal scenario of a letter or a warm transfer or even a caller ID, letting them know that this is not a spam, right? It's just the bottom line, whenever you're reaching out to the masses, it's all a numbers game. So it's all on how many people that you actually call, because that, and this is like everybody like in sales who do a lot of cold calling, we know this by heart. It's just basically whoever calls the most, you're going to have the higher number of reaches and contacts. So I mean, my personal opinion, you can take it with a grain of salt. Again, my experience is very different than what you're doing here. But to me, I don't worry about the super difficult people or the people who put up barriers or the people who I can't reach because their phone number changed and now I can't reach them anymore. It's more because it's the back of my mind. I know it's just a numbers game. I'm going to go after the lowest hanging fruit. And then once I go up to the lowest hanging fruit, I can build up my numbers from there. Increase my percentages of success on the back end of retaining the patients. So I think we discussed a little bit about some key ingredients for successful engagement. What I seem to be hearing from the group is compassion, cultural literacy, convenience, warm transfers, physician champions, working together with the provider, right? And then on the other end, we hear some new ideas, such as maybe not saying that the program is free, not overly talking about the details of the program, instead go in it with them. What's in it for me? That's another sales lingo that we know by heart. And go after what's in it for the patient right away, the benefits of the patient.
engaging them in collaborative conversations. What are they trying to get out of the chronic disease management, and not overwhelm them with too many details about the services? That's where we tend to lose people. So that's what I'm hearing. This is the thing that I want to bring up. You're not going to get everyone. And human nature, the human brain tends to remember our negative experiences as the most salient. That's the one that kind of keeps us up at night. That's the one that where we kind of ruminate over it. Like, I couldn't get that patient in through the door. What did I do wrong? But really, you're going after numbers here. You're just dealing strictly with volume. So you're going to engage the people who are at that stage and ready to talk about change. So this is, as a reminder, in the motivational interviewing world, there are people at different stages of their disease state. Some people are on the contemplation stage where they're thinking, you know, what I'm doing, I eat whatever I want, I like that, but on the other hand, it makes me feel really rotten because my A1C keeps climbing up and I'm kind of nervous about it, right? So that's kind of like, if you're having that kind of conversation where I want to stay and do what I want to keep doing, but on the other hand, I know it's bad and I want to move towards the direction of change. If you're having that seesaw conversation or that seesaw type of thinking in your head, that's when you know the patient is ready to be engaged, right? Because they're actually sitting on the stage called the contemplation stage. On the other hand, if you get patients that are firmly in the pre-contemplation stage, where they don't really care that the consequences of their poor decision or lifestyle choices, and they're not ready, they're not even thinking about the cons, they're probably not going to engage with you at this period of time. And the best thing to do is keep the lines of communication open on the chance that in the future they do reach the contemplation stage, you're there for them, right? So these are a couple of things to keep in mind. Don't sweat the people that say no. Don't sweat the wrong numbers and the people that you can't call, because it's all a numbers game and it's all about volume. You go after the lowest hanging fruit. There are ways, kind of this is like mini MI. How do you implement mini motivational interviewing in your short conversations with patients over the phone? There's something called exchange of information. And Tony probably outlined this without even realizing that he was using motivational interviewing, right? There are ways to do this in an MI consistent fashion, which is you want to limit what you offer, which is exactly what Tony brought up earlier, saying if you come in and you're introducing yourself and you start outlining all the services and what the services can do, you will lose them. 9 out of 10 times, they're going to tune out, right? And then what you do want to offer, you want to plan it to be intentional and strategic. So here's kind of like the rubric, a very simple rubric that if you can implement in your cold calling or calling patients, it can make a world of difference. Before you start offering any unsolicited advice, ask them for permission. So what are your goals? What did you know when you had the conversation with Dr. Johnson the other day? What did he tell you that he wanted you to work on? Did you agree with his or her recommendations? Why not? What do you find difficult to implement? Like when he said, try not to eat sweets. How did you feel about that? Most people would find that very challenging. What about you? And then engage them in a conversation that way, right? Tailor the information to the needs of the specific patient. Everybody, like if you operate within the what's in it for me with them, your conversation will go much further because you're tailoring the conversation to what they actually care about and what they actually want to hear. You want to provide info in a neutral, non-judgmental, open way. And many of you may have known this in my other previous sessions where I actually go in details and speak about motivational interviewing. I shared with you example from my own life. I lived with pre-diabetes and I had gone through maybe 3 or 4 years of different doctors, never taking a single medication, which is ironic since I myself is a pharmacist. I'm kind of, and I work for a pharmaceutical company, but I'm like, I don't want to take meds. And it took the 4th physician to finally, for me to convince myself to take the medication, that it would be beneficial for me, but simply because he provided it in a really open, non-judgmental tone. His tone was somewhat, you can do it, you don't have to do it, it's totally fine either way, but if you want to give your pancreas a break, why don't you try medication X, right? And it was this sort of open-minded, non-judgmental that really allowed me space to make my own decision instead of me feeling like I'm railroaded into a decision that someone else made for me. So that's the next bullet. You want to create time and space for customer to think and respond to the info, and it's a dialogue. If you feel like you're talking too much, you probably are. You want to hear, have you heard this rule of thumb? They said, if you go for a job interview, the people who step away from the job interview and then they talk to the recruiter says, how did you think you did on that job interview? I did fantastic. I'm pretty sure I'm going to get an offer today. Most of the time it's wrong. They actually don't get the offer. It's actually the people, and I've talked to many headhunters, and this is something that I pointed out that was really curious. It's actually the people who said, I don't think I did that well. And the people that said, I don't think I did that well, it's the interviewer who actually talked more. And that was the key for every headhunter that I talked to. They said the key is to have your interviewer talk more, because that's how you can gauge the level of the success of the actual job interview. If your interviewer talked more, that meant you had a successful job interview, which is completely counterintuitive, but everyone likes to hear themselves talk, I guess. That's why it is the way it is. We're gonna skip the role play. It's because it's 12:28 and I don't want to get in between you and your lunch, but these are just kind of some clinical pearls that you could hopefully come away with, taking some of those key ingredients that you mentioned and kind of like a quick snapshot way of maybe a different strategy, maybe a different way of doing things that you could start introducing little by little into your own conversation. And then you could kind of run your placebo-controlled test, do it the way that you've been doing before, see what your success rates are, and implement some of the MI strategy, exchange for info, see what your success rates are and compare the two. Okay. And if you have any, and hopefully you can continue this conversation. I know Jessica Abraham will speak later on, and she will talk to you more about kind of concrete strategies and techniques that you can utilize within the telehealth setting. And it comes to Steve.
Thanks so much. I know that some people have stepped out, but we are about 5 minutes behind schedule, so we're going to reconvene at this point.
So that's what those
Still a big mass in the room.
it seems like this far away. Most of the time they get in pretty close.
Right. So we've covered a lot already in a very little bit amount of time. Again, we've given you an update of the program. We've shared some pretty exciting new models for post-stroke care. We did a fantastic job of reviewing some of the key elements of engagement. And I think what you heard in the last section were a lot of good ideas. For example, what about the idea of sending letters in advance to patients on engaging PCPs? And I just want to share with you, those are not super easy things to do. They're definitely good ideas and what we do in integrated practices. But I think you're going to hear from LA Care and Nancy about how that actually works behind the scenes in this next session. This next session is about more application of what we heard and a little bit beyond in terms of strategies for engaging patients remotely. So I know that the vision of Cal has always been, let's create these hubs and local communities that are readily accessible to patients, right? That was the goal. But once COVID hit and we were smart enough to launch in the middle of COVID, we really weren't able to immediately jump on that opportunity. So yet today, most of the care delivered by CalRightMeds is remote. However, we are seeing some transition towards in-person care. Yet at the end of the day, the engagement of patients is typically remotely. So we're really excited to have this team of presenters share with you some best practice ideas for engaging patients remotely. And what makes them qualified? Well, the team that we're going to be having lead this presentation along with LA Care is 100% remote. This is the Virtual Pharmacist Care Center program at USC. Everything to do from MTM to CM is 100% remote. So all the issues that we just discussed about calling patients and contacting them, they do that every day. So I think it's a great opportunity to learn from the team that has plenty of experience with this. And then again, LA Care, I think, is going to bring a tremendous perspective, given that they have invested a great deal of time in a variety of key mistakes to advance this work. So I just want to quickly introduce the speakers. We have three of them. Jessica Abraham, many of you know, is on staff at the USC School of Pharmacy as the Director of Population Health and the Virtual Pharmacist Care Center. She does a lot more than that for us. Really heavily involved in collaborative in the USC Titus Center. She, as I joke, but really mean seriously, she does all the work and I just talk about it. So very, very grateful to her. Again, oversees the mid management program, the MTM program, for which we're contracted with all plans in other organizations. Her team also provides CMM to contracted entities. She's a graduate of USC. She works in a health plan for 5 years and provided frontline clinical services as well. So she has both a patient perspective as well as a provider perspective in her background. The other presenter from USC is Roya Mohajer, right? Mohajer, did I get it right? It's funny, I've known her forever, but I never had to say her last name. She's a clinical pharmacist, again, in the USC Virtual Pharmacist Care Center, a graduate of USC. Way back in 2012 already. Wow, time flies, right? And did a residency as well. We were thrilled to have her involved. She really is a true frontline expert in both clinical services and remote care. She's been part of the virtual care center since its inception, I think. Right? Yeah. And then last but not least, we have Nancy Dow from LA Care Health Plan. I think many of you know Nancy. She's the manager of ambulatory care pharmacy practice in LA Care. She not only manages the CalRightMeds division for LA Care, but she's also a frontline ambulatory care pharmacist who travels to several clinics providing CMM services. Very experienced. We have a mutual friend and mentor, Marianne Huntsman, in our past. I've been really impressed with not just her clinical skills, but her administrative skills, and really a pleasure to work with her. Like I said, I find her to be very quick, adaptive, and a great partner. So let's welcome the team up here, and we'll start the session.
No, I just told you to come back.
Hi everyone. So I'm Jessica Abraham, and since we did our intros, I'll just quickly talk. A lot of you might see some overlap between what Dre spoke about, but we're really going to try to give you the practical application and discuss how to speak about these topics and how to really engage patient and also patient, not just engagement and recruitment to the program, but also retention. Being that, you know, in CRMC, and we know it's not a one visit, it's not a one-time thing, but you know, getting them in the program and then actually keeping them in the program when you reach those clinical goals until you feel like they're ready
to, not receive the additional support and guidance that you're providing with the pharmacist team. So just, the usual, no really, financial relationships to disclose, not from myself, Nancy or Roya. And then the objectives, just quickly to go over the objectives. Roya will start out with speaking, really from a pharmacy perspective, that pharmacy-based strategy for remotely enrolling and retaining patients into a program, the CNM program like the California Readiness Cooperative. And though we don't come from a actual pharmacy, we're almost, you can think of us as a virtual pharmacy with a virtual pharmacy care center. And as Steve mentioned, all the work is through cold calling. It is for patients who aren't necessarily connected to us or don't know us. They're not the patients we dispense meds for. They're not the patients who we are, not part of their medical group or their physician group. So it does take all of that additional extra work to gain and trust and connect them. And she'll be speaking about some of those strategies. And then we'll hear from Nancy, speaking from the health plan perspective and other stakeholders, and what else can you use if you can't think of everything you can do within your pharmacy? Can you use other things that are provided to you, other resources available to from your health plan? And then last, we're going to do a very, very quick just reminder about patient privacy violations. And just making sure that we adhere to HIPAA in the course of delivering telehealth at CME, because we talk so much about the importance of recruiting these patients and doing everything you can to recruit them and retain them in the program, but we also always just have to be reminded of the HIPAA in the background and making sure to protect patient health information. So with that, I will continue it.
Good afternoon, everyone. So on the flip side, we have the benefit of speaking with you guys after lunch. So hopefully everyone's awake.
Yeah.
And so what I want to really touch on is what we're doing practically in the virtual pharmacist care center and how those have translated to success for us and how we can kind of work through obstacles that you're experiencing to have success for your pharmacy as well. So like Jessica said, we may not be a traditional pharmacy, but we are providing all our services virtually. And so we want to share the practical examples that have made success. So I know that Tree talked a lot about, or like touched upon in the survey about the things that are preventing patients from being recruited. So are there any obstacles that weren't mentioned or that you want to share that you're experiencing in your pharmacy? It's okay if you haven't, if it was all touched upon, that's fine. But if there's anything different, please share so that we can all consult and kind of reflect on it. Well, if something does come up, please raise your hand. Again, it's supposed to be interactive, a discussion. We will have the opportunity to role play. So if something arises, please feel free to raise your hand. All right, so I know that we touched upon scripts. And so one thing for us that we've been really integral in refining and adjusting is how are we talking to our patients? And so someone already mentioned, once I get them actually willing to speak with me, it shouldn't be a problem to kind of reel them in and enroll them in the program. And so that's kind of something that we really try to refine and modify as much as possible, because we're doing everything over the phone, right? So we have maybe 5 seconds to introduce our pitch, and it might vary, right? So I know that we talked about leveraging, where you're, I'm calling from USC. I'm calling on behalf of your doctor. I'm calling on behalf of your health plan. It's going to be different as far as what people communicate with. We've seen in our practice that using USC is a big turnoff for people sometimes. I'm not from USC. I have no idea what you want. That's not me. Wrong person, right? So it's kind of figuring out your patient population and what's going to work for them. So what we've seen in our practice is saying things like, we're calling on behalf of your health plan. And maybe not even saying health plan. I'm calling on behalf of LA Care. I'm calling on behalf of Blue Shield, right? So using very practical things that the patient can relate to. And when they hear their health plan's name, they're more inclined to be like, oh, yes, what how can I help you, right? So instead of automatically wanting to hang up on us, we gained a little bit of traction and trust from that perspective. So once we've gained that trust and that perspective, there's other ways that you can gain the trust. We've talked about trust. So something that we've also implemented is sending out letters ahead of time and saying, hi, you might receive a call from USC. We are partnering with your health plan. They're partnering with us to work with you.
And so those are different things that have helped. Some people will then have that be a point of contention. I haven't received a letter. So it's working through what you think is going to work best in your script. And that might be adjusted entirely based on how you're running your pharmacy. Something else we've seen that's helped is we are implementing the use of an auto dialer. So cold calling can be rough, right? So you could spend your whole day leaving voicemails. And so we're trying different things to kind of work through that. And that's using an auto dialer so that we can connect to a live person. And by connecting to the live person, we can have our time better spent doing clinical services at that time. Now, with the auto dialer, that's something great that we're also implementing is potentially having that health plan be on the caller ID. So a lot of times we'll have people say, well, the caller ID says this, or it said your spam, whatnot, right? So we're trying to gain the trust in the little ways that we can, which is, for instance, having the health plan be on the caller ID when they call in. And that's a prequel that we did get from the health plan. That was okay for us to do. So now that we've done all of this, it may come down to just how you're communicating with your patients. If marketing yourself, marketing your program isn't your forte, you got to get comfortable with it, right? And it's also important to note that you as a pharmacist don't have to do it all, right? We have support staff, and speaking from our own experience at the Virtual Pharmacist Care Center, we have different support staff that are not pharmacists, who are wonderful at patient engagement, and we get feedback that, oh, can I, give a positive feedback for you? She wears compassion and empathy on her sleeve, right? So she's able to connect with them, and the minute they're talking with her, they feel very comfortable and trustworthy to go on and speak with her about the clinical services she's calling about. Now, it's going to be really dependent on how you connect. We talked about connection. And so the compassion and the empathy is something that you can use. What is it that's going to connect you with your patient? If it's someone you've spoken to before or worked with before, you might know that, and you can leverage that to speak with them. If it's something you don't know, you can kind of just work through that, just as if how we have been doing with cold calling, is just having a more compassionate tone and speaking with them. And also, it's important, once you're able to speak with them, what is it you want them to know about your program? We talked about talking about the services. We've talked about not talking about the services. So what is it you want them to know? It might be a real practical thing about logistics, and it might be practical about the time being spent. But those are the things you're going to tailor to your own scripts. Now, I know the CRMC provides scripts to their pharmacies and their pharmacists to use. So again, if you're not comfortable, use those scripts until you can get comfortable marketing a program such as this. And as you do that more, it's all about experience. You're just going to get more and more comfortable speaking with people, and you're going to adjust it based on your own style, which is actually probably the most comfortable for you and for the patient, right? It can sound pretty robotic reading from something, but that's the point, is to get comfortable. And that's how we train our team as well, is, we give them all the official stuff, and we see over time that it completely morphs to what works for them, obviously maintaining HIPAA and all of the things that come with it. So going back to compassion and empathy, I think patients can very much tell when you are reaching out to them with concern about their health and how you can empower them. They'll know the difference between that and if you're just calling to bill for a service, right? Like, that's a huge thing that they are going to be able to tell. And if that's not your strong suit, find someone on your staff that has that ability to connect, because it'll make the biggest difference as far as enrollment and people actually choosing to enroll and recruit to your program. Now, when all of that fails and they don't really want to know about compassion or empathy, let's talk about incentives, just to be practical, right? So we've also touched on incentives and things that you can offer, and that might be the thing that you need to pivot to with your script. And so talking about, if you sign up, you could get a free, right? That might be something that could motivate them. They don't have a blood pressure machine at home and they would really like to keep track of their blood pressure. It's helpful for them. Those are things you can provide. And you might think, oh, well, I don't have the means to give out free blood pressure machines to all the people that want to come. A lot of times health plans will pay for these things. And it might be you or your staff that can provide the extra steps that will do that for them. That's a big incentive for patients who don't know that that's even an option. And you can provide that extra step. You can say, supply of diabetes supplies, or, the free blood pressure machine is huge. I know in previous years, our clients have offered free flu shots. So when you're enrolled in the program, you can come back and you can get a free flu shot with us. If there are other things you offer in your pharmacy, coupons, delivery fee waivers, right? So a lot of the social constraints we talked about as far as transportation goes, adherence, all these can be affected by just what they have the means to do. So providing those things. I know that Nancy's going to really reflect in detail on what these incentives are. But it's leveraging the health plan to provide these incentives and how you can initially get them to enroll, right? And hopefully continue in the program as well. So besides the incentives, you can also, draw upon the other clinical services that you might have at your pharmacy. And that might be something like meal plan services, exercise programs, or even a smoking cessation program. So again, it's kind of thinking a little bit outside the box of what you can also offer. That would be incentivizing the patient to want to continue and enroll. So I know Drew didn't get to role playing, but we thought it might be useful at your tables if you can work with whoever's there to just simply role play as if you're a patient and you are talking to a pharmacist who's interested in enrolling you in their blood pressure program, for instance, or hypertension program. So what do we look like? 3 to 5 minutes? And then we can just do some role play. And we can also reflect on what we learned in Dree's presentation as well, since I know she didn't get the chance to have any role play. Yeah, right now. So one person can be the pharmacist, one person can be the patient.
So they're getting. We're missing one.
Well, I think one of the ladies took it out there. I did. Okay. Thanks. You sign in already? He's on the board.
Think so. Is there, yeah. Did you?
I came right in here because I wasn't sure what I was gonna see when I came in.
Yeah.
They hadn't built the stage when we left.
Oh, really? Was the wall open?
The wall was open, yes.
So they were starting to work on it anyhow.
Right, does everyone need more time or we feel good about? The last couple minutes? Okay, so is there any kind of wisdom or clinical or like any pearls that came out of that role play that you would want to share? Like an example of maybe yeah, what could the patient say that you would want to work through? It seems like you guys had a fruitful session, so let's give you
So really, we really did not do a real role play, but the way I started was, hey, Ramesh, I see that, you need to control your blood pressure. So how about I give you a machine that will get the things controlled and show you how to do this? And so that's where we started, and then we digressed into diabetic supply. So I apologize. So we need intention to.
Okay, so you led with like the BP machine, right? And so that's a good strategy too, that kind of gets them in the door.
So basically to engage him was to entice him to say, hey, listen, I'm gonna give you a blood pressure machine, I'm gonna show you how to work. And so usually in my pharmacy, I have a page that says, blood pressure takes on morning, afternoon, evening. So I give them that and say, okay, start recording it. So when you come next time, then we can see that. So obviously just engaging the right. Yeah. So that's how we started here.
Right. Okay. So no, that's great. Thank you for sharing. Anyone else? Maybe one more kind of something that their strategy that's successful. Oh, and Whitney's worked with us, so she knows.
Hi, guys.
Hi.
So I think I just went straight into it. I just told them, oh, what do you think about this service that's provided to you by your health plan? All you need is to come in, we just need intake, and then we can provide you with tools and resources to help you maintain a fulfilling life. And I think that's what captured them in. I just wanted to say, I know that we have all discussed about the scam likely generation and how things may sound very difficult to patients, especially when you're trying to kind of sell them something over the phone. And I think once you get through that initial success of getting them to buy in, I think the HIPAA part is now the part that becomes like a full stop for patients. So like verifying who they are, they're like, okay, well, why do you need that information? So that was kind of like a barrier, which I'm pretty sure we'll get into because you guys mentioned that. But yeah, it was very fun. And I guess greater context, I've been working with you guys before. So even the scripts and everything that you guys are saying, that's what I'm using with where I'm working at now. So I really appreciate you guys coming out to talk to us.
Great. Thanks, Whitney.
Well, I'm glad you said it was fun because I was trying to give you a really hard. The guy was accusing her of scamming and also I think one other thing that I was giving her a hard time about is that I think a lot of other everybody else in the audience have probably seen this, is that people would just say, I don't have time for this, right? A lot of times if you're trying to enroll somebody and offer some sort of service, or they're expecting the call to take like 10 minutes, and with everything busy, things going on in everybody's lives. So
sometimes like things that I do in my practice now, as I have coached my teams, that we just want to start off with something that saying, hey, this will just take 2 minutes. Or, I mean, it's probably a little unrealistic, but I think once we reel them in and we get the conversation started, the patients themselves, they'll lose track of time and they want to do more of the talking.
Yeah, and we sometimes use the word quickly, right? Just to be like, we just really need to quickly speak with you, and then it becomes a longer conversation. It's about gaining that trust, and sometimes once they have that trust, then they're willing to speak with you more. So before I close out my piece, I just wanted to reflect on barriers. So once you have enrollment in the program, there might be other things that come up that you're not retaining those patients in your program anymore, right? So you've done the hard part. You reached out, they've agreed to come, and then there's different things that are going to come up. So for instance, transportation. I know a lot of this is telemedicine. So reminding them that you are kind of you're an access point for them. They might not be able to always get to doctor appointments. They might not be able even to get a doctor's appointment. And working with you, you're eliminating that need. Now, if this is a patient you think can really benefit from an in-person consultation or an in-person visit, again, tapping in and leveraging the health plan. There are transportation coupons. There are different coupons or vouchers that you can get from the health plan that will assist with this, which I know Nancy is going to be speaking about as well. There's a lot of patients we speak to that are like, I'm fine. I don't need anyone to help with my medications. Or if you even remotely suggest that they would need an additional medication, they feel like Hilbert is, and so that's where we're gaining the trust for them to reflect back on the disease they might have had for 20 plus years and how some things are not changing, right? So it's getting them on an optimal regimen. And I just want to reflect a little bit on what Steve said is how, the local pharmacy is going to be the place that they have access to someone who can care for them. And in addition to that, this is truly, for us, at least, that what we always like to do for our patients is an empowerment program, right? And so they're becoming stakeholders in their own health a little bit at this point. They're not hopefully having someone who's just talking to them the entire time, sending them home or getting off the phone with them, but actually empowering them to kind of be a little bit more involved in their treatment plan and in what's going to work for them. That's gaining trust with them. That's them being open to your treatment plan. Language is obviously a huge thing, and I know a couple of you guys in the audience have mentioned that language is huge. That's also something that Nancy's going to talk about, and how the health plans can assist with the language piece. And then for the pharmacy itself. So you pharmacists out there, you don't have to do it all. We talked about this, and it's using your staff, right? So you don't have to. Your support staff is not necessarily giving any clinical suggestions or clinical counseling. If they're reaching out, they may be your strongest patient engagement advocate that you have as staff. So utilize that, use that, and kind of allocate your staff appropriately to where their strengths are. And it doesn't have to be all on you, is what I wanted to close. But thank you. Sorry, I realized we were in discussion. So now that we've had Dre's piece and we shared some of our practical examples, what changes would you implement in your pharmacy based on what we've just discussed, and things that can make a positive change in helping you either enroll patients, engage patients, retain patients? So if you want to anyone want to raise their hand and think of some practical examples that changes you might make at your actual practice site?
Yeah, I was gonna say, we always like to give you homework, so we need to make sure that we and truly make a change, something that doesn't exist in your pharmacy now that you're planning on implementing, whether that's using your technician more, using your interns more, using a clerk more, thinking someone on your staff. When Roy was saying, I do know this person speaks so great to my patients that I dispense meds to. Why don't I pull them in and maybe utilize them here? So just think of maybe 1 or 2 things that you'll do that is new after leaving from today.
Technically, I'm not a part of this yet, but I already talked to my delivery driver before coming here. I contracted him, so he's his own business, but he was already willing to become the CHW,
And I was like, so you're going to take an iPad with you and we can have discussions and stuff. It's like, yeah, do that. How much do you charge for that? And he was like, no, I just want to keep the patients happy. So I'll do it for free. I'm like, that's really cool. Very creative too.
So I know I'm not a pharmacy, but I'll share a confession, very much what you just said. So I remember one of the first programs that I was put in charge of when I finished my residency was a severe hypertension program. So I was excited because I'm looking at all these medication regimens. I can see what's wrong, because we're all trained to do this. We know exactly what's wrong with the regimen. And so the patients come in, I interview them, I'm telling them, oh yeah, we definitely help you out here and can easily make a few changes here and there. Right? I'm saying this out loud. I never saw them again. Okay, because what are they thinking? They're thinking, I have a trusted physician. Here's this guy. It seems like he has good intentions, but I don't want him to touch my medication, right? So my switch became never talking about changing medications, but finding out what goes you have here, what concerns you the most. Give them free space to talk, addressing some of those concerns, and that's how you hook them in and get better to start talking about things.
Very true. Giving them the space is always helpful. For some people, it's essential. Right, next we have one more. Oh, one more. Awesome. Yeah.
I just wanted to ask,
Yeah.
you're mentioning automatic earlier.
Yes.
Did you go into any detail on that? Because I think that's a fascinating idea.
Yeah, I didn't go too detailed into it. It's just one of our strategies that we've been implementing. So we are using a company that provides auto dialing. And so what it essentially does is we give them, our patients, our numbers, and once it's loaded, and again, there is a lot of back end building of a program like this, because you don't want them to be called again, et cetera, right? So there's like a different system, but essentially, it will connect you with a live person. And if they get a voicemail, the auto dialer has a pre-recorded voicemail that would play for the voicemail. And then it would drop obviously any calls that are busy tone, invalid numbers, et cetera. And then ideally connecting our team with a live person. So it kind of eliminates, a day full of voicemails, for instance.
Do you mind telling us what company?
I don't know. If we use 5-9. 5-9, but we're it's growing pains, I can admittedly say. So we're working through that, but we use 5-9 currently.
And then the only other concern I have, Matt, I think it's a great idea to you mentioned it, it's a numbers game.
Yeah.
The other question I had is, how do you deal with it? Is that some kind of challenge?
It is, and so Jeff is gonna go into more detail with HIPAA, but we do have real examples of where it's been a roadblock for us, where you can get in trouble if you're not really following it kind of exactly. But after Nancy's piece, Jessica will go into HIPAA. That's really
yeah, thank you.
Hi everyone, my name is Nancy. I am the manager of ambulatory care and the LA Care Health Plan, and I oversee the CRMC project from the LA Care Plan side. So Ray did a really great job on talking about her strategies on how to build a script so that you can connect with patients and get them to join the program. But in reality, even when you give your best elevator speech, it doesn't always work, right? Our profession has built this idea of what a pharmacist is over many years, and it's very hard to break that perception for many patients. So even if you give your best elevator speech, sometimes it just doesn't hit. And right, and for us to think that in a 2-minute phone call, we can change their entire perception of the profession is very unlikely. And it's probably not going to happen for most people. So what I'm going to do today is hopefully give you some ideas of how you can kind of quickly adapt during the phone call so that you can address their concerns a little bit better and maybe entice them and engage them with ideas that maybe they care about more. And then you can come in later with the pharmacy stuff when it makes more sense to bring it up to them. So when you're talking to a patient and you're not really connecting with them, they don't really understand, why you're calling them. They already have a litany of excuses of why they don't need to see you, right? I don't have any problem with my medications. My doctor already told me how to take them. My daughter is a nurse, right? We always get these random excuses on why they don't need our help. And for us to think that within that 2-minute phone call, we can convince them that there is a problem with their medications, that maybe their doctor didn't tell them everything they needed to know about that medication, sometimes that's not the best way forward. So one thing that you can do is, as you're actively listening to the patient and their concerns, or maybe their excuses on why they can't see you, whether it be transportation, whether it be time constraints in general, if you guys understand kind of what the health plan offers, you can offset that, right? You can actually address the concerns that they're bringing up to you before you even get to the medication part, which is the job you're there to do. So understanding plan benefits, like what transportation benefits are covered. Did you know that our Medicare patients get monthly allowance for groceries, right? Monthly allowances for OTC medications. All these things that the health plan offers that offsets your costs, right? You don't have to figure out how to solve that problem for them. We probably already have something in place that you could tap into if you knew it existed, right? Our plan benefits on the website. It's on the website for most all plans. You can hop in there and see what it is that we offer. And then from there, take it a step further, right? How do you enroll a patient into the program? Many times we always think that the provider is the gatekeeper to all resources, but they're really not, right? Transportation can be initiated by the patient, right? We have an online health coaching program that doesn't need PCP sign-off at all. Right. And once you realize like what are the things that the patient can be empowered to pursue on their own and the things that you can assist them with, you're able to build your value proposition to the patient. Like we obviously know that they don't really care about what you have to say in terms of their medication management in this moment. But if you can communicate to them like, hey, you're telling me you have this problem and I know a way to fix it that on the plus side is at no cost to your pharmacy. Use it, right? Throw our name in the hat. Let them know, like, oh, LA Care, your health plan offers this. Would you be interested? And then you can throw in your pharmacy stuff later. So a strategy I use all the time in clinic because I'm still cold calling patients to find patients to see, right? So I had a patient that told me like, oh, I'm having issues with my medications. I've been losing a lot of weight these past few months, so I don't actually need any help with medication. I think it's working well, right? And so when I honed in, I was like, oh, you're losing weight. So I offer different programs like, oh, LA Care, we have a program for weight management and like online health coaching that can probably make you get results faster. Like, do you want me to refer you to that program? And you're like, yeah, I guess whatever works. And then I slide in and said, well, I should have an update for you for that referral in about a week. Can I call you on Monday at 1 o'clock? And then actually while we're there, let's go through your medications because some of your diabetes medications can cause weight gain. How does that sound? Right. So without making it very obvious, I scheduled them an appointment and I got a med in. So that's kind of how you squeeze that in. You don't have to tell them upfront everything that you want to do in that initial phone call because some patients just might not understand it, and that's okay. But you need to create an opportunity for a follow-up so that you can demonstrate your value later. And maybe the value that you demonstrate in your initial call is just the wealth of knowledge that you have about things that they might care about, but they didn't know that they wanted to know from you. And that's how you can leverage the health plan resources. And then the most important thing that I always encourage everyone to utilize is the interpreter services. So as part of CRMC, you guys can use our interpreter services for free, right? If you have patients that are deaf and use sign language, you can schedule an Excel interpreter to come to provider visits. So once you're able to kind of connect the dots and get the patient kind of involved and maybe a little bit excited to see you and maybe see what other things you can help them do, it really does make a world of a difference. And I want to go into a little bit more detail about interpreter services because in reality, a lot of independent pharmacies, and the reason why we love you guys is many patients or many pharmacists are already bilingual, trilingual. You have technicians that are also bilingual, and we utilize them in a way to make sure that we can connect to our patients, right? But ideally, you need to build rapport. with a patient, not your technicians, right? Although it really helps immensely, you need to build that rapport with them because technicians can come and go, but if you're independent pharmacy owner, that's your pharmacy. You're sticking around for a while, right? So using our healthcare resources for interpreter services can really help you build that rapport. Because once you're able to build rapport with the member, you're able to communicate with them effectively, you're able to ask the important questions, right? Because let's be honest, 99% of my patients speak Spanish. I am obviously not a native Spanish speaker, right? And a very small selection of my patients actually speak English. But if I reflect on my interactions between those two cohorts of patients, they get a different version of Nancy, right? My English speaking patients get, hey, how's your daughter? What's she studying in school? You know, I heard your kids graduated. How's your fun going? Like, how's the family doing? My Spanish patients, sometimes they don't get that, right? Going beyond like, hey, how are you? How are things going? Is very difficult. And even if I do prepare my Spanish to ask this open-ended questions, you know, God help me that I can understand what they're saying back. Right? So using medical interpreters is very, very important for you to build rapport because it's not equitable care. They shouldn't be getting different versions of Nancy when I'm seeing people. They should be getting the same nice, friendly, relatable Nancy every time. Because at the end of the day, that's before they can even see your value, you have to be likable. And if you can't do the small talk, chances are they're not going to want to come back to you if you can't do that small talk. Right. So for those who may not use medical interpreters very often, or maybe you guys use your staff to do it, just some tips to make sure that we are keeping the appointment well run, right? So know in mind ahead of time that appointments with patients when you need to use medical interpreter is going to take longer. You need a plan for it. Right, if you're using your staff, you know, to do the medical interpreting, they're going to be pulled away from their usual duties. So you need a plan around that, right? Same thing, if you're not using your staff and you're using the interpreter online, that appointment's going to get a little bit longer, right? So plan accordingly, be strategic on when you schedule those appointments. Next thing is to give your interpreter, whether it be your staff member or the interpreter line context for the visit. Let them know that, hey, I'm calling to schedule a visit. I'm calling to introduce a program to them. I'm calling to conduct a visit, right? And for your staff, let them know the questions they're going to ask. Because our staff aren't, you know, certified for medical interpreting, they might need to look up some words before you see the patient, right? Give them time. Be like, hey, these are the questions I'm going to ask them. Can you prepare? Right? Give them time to set them up for success, right? They might have to look up a few things before you see them, but it allows them to have more confidence when doing the visit, and it allows them to be actually more adaptable during the visit because they're in the right frame of mind when they're conducting the visit with you. And then the second thing is have your interpreter introduce to you. Right? You can avoid that whole awkwardness of saying hi and then looking at your staff members like do the introduction for you. Have your staff member do the introduction first. Like, hi, my name is so-and-so, I'll be interpreting, this is my pharmacist. And then the interpreter will do the same thing if you're using the interpreter online. Have them introduce you first, so it's a little bit less awkward. You kind of jump right into it with a small talk. The second last bullet point is to speak to the patient, not the interpreter, right? You're trying to build rapport with the patient. So it's actually easy for the interpreter to do medical translating when you're asking questions directly to the patient versus you telling people like, oh, now can you answer if any hypoglycemia? Because the interpreter will have to take your instruction formally in sentence and then, you know, spit it back out. Whereas if you just ask the patient directly, they can more readily translate for you. Right. So always speak to the patient, always make eye contact with them. If you're using a staff member or some other interpretive service for in-person appointments, you're always talking to the patient. And then the last thing is your interpretation should have a sentence by sentence, and it shouldn't be too long, right? Whether you're using a professional service or whether you're using your staff members, no more than 3 things in a sentence, right? Are you experiencing any low blood sugar symptoms like shakiness or sweating? Don't start looking at all the possible symptoms. Keep it short and sweet. Take out any fluff questions, right? Asking questions like, oh, you started metformin, how's that going? What you really meant was, are you experiencing any side effects such as X, Y, and Z? So just ask them. right? Because your patients don't have framework, like, what do you mean, how's it going? Like, I took it, but what more do you want to know? So get straight to the point. You already know what is at the heart of your question, so just go ahead and ask it, and naturally other conversational pieces will come out when you're kind of managing your time and taking out all those extra questions. So hopefully with this slide, it can build some sort of comfort in terms of using medical interpreters, whether you use your staff or you use a professional interpreter line. Right. And from there, you're able to communicate with the patient. You can, like I said, start asking questions that really matter to them. You know, what worries you about your health? What do you hope to get out of these appointments with us? Right. Like, where did you imagine you would be, 6 months from now if everything went right? And then from there, you can start connecting them with other resources that can help them get there. Like I said, our patients are very complicated, and yes, they need medication management for sure, but they need so many other things that complicates their care. And so for LA Care, and anyone's free to use it, we compiled a database of different community-based organizations that address certain social determinants of health. If a patient has trouble with housing or transportation, finances, education, employment, we have job fairs. You can go on our website and look at those organizations and what's available to your patient. This is available to all community members, not only our members, right? Because from a health plan level, we're not only investing into our members, but into the communities that they live, because everyone needs to be healthy for our member to be healthy as well. We're building safe neighborhoods, right? And making sure that we're being equitable in how we spend our resources. So this is a great resource for you guys. Even if you're not part of CRMC, please log on and see what's available, and look through the eligibility criteria to see maybe you have a patient that could benefit from one of these programs, and you can definitely build rapport with them that way. And then lastly, health plans, we always, like I said, invest in our communities, and there's also available programs that exist outside of us, right? So at LA Care in particular, we actually have brick and mortar places where it's in partnership with Blue Shield, where patients and everyone in the community can come and access. So at the end of this year, we should have about 14 total centers all around LA County. And at these centers, we have free Wi-Fi, free food pantries, enrollment support for people having issues with their insurance coverage, linkage to assistance programs, free Zumba classes, technology classes, cooking demonstrations, all these things that we offer. It allows the patient to connect with us in a way that traditionally they couldn't do before, right? The only way to reach us previously was to call member services. And we all know that journey, it's a journey to talk to someone that can actually help you. So we're investing in our communities and building kind of brick and mortar places so that the member has a way to communicate with us, get feedback from us, and really change the dynamics of our traditional relationship that we would typically have with a member. And as a community pharmacist out in the community, it's really important that you guys know what's available to them, not only through the health plan, but the community-based organizations that are already in your communities, the other small businesses and nonprofits that are around your pharmacy that can assist your patient in becoming healthier. Because we all have the same goal, we just have a little bit of a different role. And so I hope that was helpful to you guys when, like I said, we might be able to give our best elevator speech and it still won't work, right? So hopefully you guys have some ideas brewing in your mind to potentially be able to pivot the conversation very quickly when you realize that you're not really making progress within that introductory phone call. And that will conclude my slides. We do have a quick question on how can you leverage health plan or other stakeholders to enroll or retain patients. So you guys can talk amongst yourselves, but have a couple of minutes to talk about it, and I hope to hear some great examples, and I hope that I spurred some ideas at the tables here. Thank you. Minutes to discuss and then report back. All right, so we'll have 2 minutes to kind of discuss them all yourselves, and then I'll go around and gather some comments. All right, let's go ahead and wrap up discussion. Does anyone want to share kind of how they leverage different health plan resources to engage the patient and get them to continue seeing you, or maybe to enroll them into CRMC or any other clinical service you have? Let's say something. Go ahead.
I'm Stacy. So I would use the food pantry services that like Care has. I would also try to entice the patients by joining the program. If you want to speak to a nutritionist, I can refer you to someone, or maybe with behavioral health.
Perfect. I know Stacy does a lot. They're one of the most active pharmacists next to Janice, right next to her. I see her too. And I know all the referrals that she's submitted when she sees her patients as well. Does anyone else have anything else to share? Yeah.
Yeah, 2 questions.
Mm-hmm.
First of all, my pharmacy is in Riverside County in the Empire, and I'm very jealous now from all the goodies and the good stuff you guys are offering in LA.
Good.
Do we have something like that on the other side? Where we are?
I will defer to an IHP or other plans that can answer that a little bit better than me. I'm unfamiliar on the other side.
Okay,
we have money.
but the patient has to have IHP. What about the ones who has health net? Can they come and take advantage of just on the IHP? No. So if it's possible, you guys can give me those resources so I can help the patients. I would really appreciate it.
Yeah, we have plenty of resources on our website that's actually open to anyone. They don't have to be a member to participate in them. Yeah, so yeah, I can definitely send you some resources. I'll find you after and I'll reach out to you.
Thank you. Number 2, you said a lot of the referrals can be done without the physician's signature.
Yeah.
How to do that? I've never heard that.
Yeah, so a lot of things that the member can initiate on their own, or that you can help them is like transportation. They don't need a physician sign off for transportation. Unlimited trips. Yeah, so there's that. Behavioral health also does not need a PCP signature. They can initiate that on their own. Our health education courses, so diabetes prevention programs, diabetes self-management, our online health coaching, all that is available to members without needing a PCP signature. There are some things that need PCP signature, right? You want to see a specialist. If you need a special type of transportation, like you're wheelchair bound and there's a particular type of vehicle that you need to take you around, that's a physician sign off. But and I would assume for IHP and many other health plans, if you go on their website, you can see exactly what programs are available to the member. And it'll tell you if they need a physician signature or not. And they can always call member services firm. And then the other nice thing about CRMC is that our pharmacists have a direct line to us. So they can always ask us if they have any additional questions. But there are a lot of programs that the PCP, they don't need to sign anything. It can be a lot of community support programs can be initiated by the member if they say they're interested. And then the PCP will be notified, but they're not the gatekeeper for a lot of these programs.
Thank you so much.
I just wanted to add that I think one of the important things for pharmacists and support staff to know is to kind of like educate yourself into what the health plan offers. Because I think that although I haven't really started with any CRMC patients yet, one of the things that I come across is that patients just don't know what's covered, or they don't know what they can do under their health plan. So that's educating ourselves, knowing what the health plan does, and basically encouraging the patients not to feel guilty about doing some things. Because I remember I had a patient who's guilty about going to the food pantry, and it's like, no, that's what it's there for. So also like motivating our patients to take advantage of these resources that someone is paying for. So yeah.
Yes, exactly. And besides work too, Whitney, you really find work too. In fact. Yeah, any additional comments or questions at all? But Whitney's exactly right, is understanding what the health plan offers and what the patient can be empowered to achieve on their own. And many times in the community setting, we always can default to ask your doctor. Next time you see them, call them about this, call them about that. But honestly, a lot of things, we can do on our own, and by understanding what we can do on our own, we're able to kind of change that narrative for the patient that, the PCP is actually the gatekeeper for this, like you are, right, the patient, and we can assist them in that journey. So thank you guys so much. We have a little bit more on that board that's gonna go over.
All right, so the last topic, basically saving the driest topic for the end, but we're hoping we'll get you to actually discuss together and kind of tell us what's working at your sites, and we'll give you a little bit of a few examples of things that we do at our virtual pharmacy care center. So despite everything we said about like almost really doing everything in your power to recruit this patient and keep this patient in your programs, patient recruitment can be tricky because as we try to connect with the patient more and more, we have to be very careful not to accidentally or unintentionally reveal any information that should be really protected by HIPAA. So everyone, of course, knows what HIPAA is, but just as a reminder, it's a federal law that is required and sets out national standards to ensure that we protect the patient's sensitive health information from being disclosed without the patient's consent or knowledge. So we know, even from real life examples, because everything is cold calling and because we're constantly training our technicians and our students, interns, etc., to make these outreach calls and try so hard to connect to the patient and convince them of the importance of this program, that sometimes in doing so, and sometimes in trying to gain their trust, we can unintentionally reveal something about the patient that we should not have done. A prime example, and I think a lot of us don't think about this, is we sometimes say we're calling to talk to you about your blood pressure or about your diabetes or about your something without having verified first that this patient was who they were. And in just saying that one piece of information and inferring that one piece of information about them that you did have, that the health plan did send you, that was protected information as it was transmitted between the health plan and you, it wasn't protected for you to reveal to that other end user on the phone who answered the phone. So as you all know, obviously the HIPAA privacy rule and the HIPAA security rule really address what you're seeing in these three columns. And I'll leave all the information there just as informational for you. But you are considered a covered entity because you're a healthcare provider, so you have to adhere to the requirements set forth by HIPAA. What we do at our virtual pharmacist care center, and which really is a best standard practice across is utilizing the two patient identifiers. So the Joint Commission, most of you guys know as JCO, the Joint Commission on Accreditation of Healthcare Organizations, is a global driver of quality improvement in patient safety and health. So one of their standards is the requirement to utilize two patient identifiers to identify the person you're speaking to, the person you were trying to call, and to verify that the service or treatment is for that patient. So this is a hard piece, like Whitney had brought up, because you were trying to convince the patient of joining this program, and before you can really tell them much about the program, you need them to verify, to confirm with you at least like their patient full name, date of birth, or an address, or maybe their ID number on their insurance card, or some piece of information
identifiable, health information about them or individually identifiable information before you can, provide further information about the program or why you're calling them or really why you want to recruit them. We talked about scripting, a common thing that we say in our in those outreach calls is really it's to protect your privacy. You know, we use that language to really get them to realize that this is really to protect them. Other things that we have at the Virtual Pharmacy Care Center is we have like a contact, and I know at the CRMC, like you have a contact at your health. So if it's a patient that, you know, is really having trust issues, really does think it's a fraudulent call, we can connect them. We can actually three-way them while we have them on the phone, in some instances, to a contact that we have at the health plan who will verify for them right away. Sometimes that doesn't even, sometimes they think you're going to three-way with them, with someone that you pre-planned for, you know, to speak to them and to pretend that they're the health. So sometimes it's a matter of giving them the phone number or telling them to turn their you know, health insurance card, call member services, verify the information, and then you'll call them tomorrow or the day after to then speak to them. We talked about patient letters. So patient letters are something that our partner health plans will send to the patients, letting them know about the partnership, verifying the partnership. There are instances where the patient says, I didn't get it. So then we connect back with the health plan, we have to resend a letter, and then we call them and like, so I think it's important to basically not give up and to, you know, to continue to try to work beyond that, because in the course of telehealth, that's always going to be an issue with patients not being sure that you are who you are, and you know that the services you're providing them are from, you know, a reliable, trustworthy place. We talked about caller ID, having the health plan's name show up. So just, you know, multiple different things. And then at the end, knowing that if there is no way around it, you just can't be in the patient's trust, that you shouldn't, you know, reveal any information. That, you know, if at the end of the day you have to decline offering the service, that in itself might actually make them trust more. And you can leave your contact information. You can tell them, you know, when they feel comfortable or when they verify the information, please call us back, because we want to make sure that they can take advantage of the service that's available to you. And this is important in training your staff, because you know, we all have other clinical support staff, whether maybe technicians, students, etc., that aren't 100% sure or might take the script and we said, you know, we say things like tweak the script to your needs and to what you need to do during that call. But we have to remember that when we say those things, that we don't reveal any patient information during that call. So over here, you have 18 PHI identifiers. Definitely won't go over it more for your reference, because there are some things too that patient is willing to confirm that are not the usual things we think about. Some things are like, I'm not giving you my date of birth, I'm not giving you my address, but I'll give you my fax phone number and you might have the fax number. So there are other things you can try to verify with them. And I kind of wanted to turn it to you all, because I know we don't have time for it. In your folders, and this will be kind of homework, there is a patient case, and what we have is on the first side of that page is the very limited information that you usually get when a patient is referred to, because that's part of HIPAA, whether you're getting information from LA Care or Inland Empire or any health plan in CRMC, you're probably not receiving like a full patient profile. You're getting limited information just to start the outreach. So I think it's important to read that little bit of information and know how you would use it to do patient recruitment versus that patient case. Now the patient's enrolled in the program. Now they might not want to stay in the program because they feel like they have it under control. And this happens a lot with pharmacy services. We give so much information up front, and now they feel like, okay, now I know everything. I can kind of do this on my own. I don't want to continue to spend all this time. So now it's about patient attention. We'll go over that later, because I want to make sure that we save enough time for our other speakers. But what I do want to end with right now is having you kind of discuss in your groups, and I definitely want to hear from you, because we're also going to learn from you. What do you do in your pharmacies when you're trying to recruit patients and you are dealing with this patient who just really thinks you're, you know, fraudulent, it's a scam call? What tactics do you do without revealing PHI
that have been helpful or, have helped you recruit patients. I gave some examples of things we do, but we'd love to hear from you as well. So we'll give you 2 minutes, just to really hone in on this and what you do to maintain HIPAA amongst your team and what you do to recruit patients despite this trend that we see with, pharmacies, patients being uncomfortable with telehealth services and not being sure that you are who you say you are.
Right now, table over here. I've been asking them all day why that table. I put the tablecloth on it. Keith, I gotta go to the restroom. Get over here. I don't know what could possibly happen, but I'll be back.
Stop the clicker, right? Just put it.
Yeah.
All right.
All right, so maybe Michelle will go around and just get maybe 2 examples, because I think this is really helpful information for us, especially if you have new ideas and things we didn't mention that have worked at your sites.
We were having some discussion at our table. One of the things that I've had to implement being at a new place is name dropping the other staff members to get patients comfortable. So saying, oh, I'm the newest, I'm newest member of the staff here. I've spoken to this person and this person, that I'm here to kind of serve you as well. Another thing is, especially when you've already developed a relationship with the patient, just kind of telling them, I know your voice, but can you just verify these few things for me before we get started today? I think that's really good as well, because sometimes it can be very robotic, asking them the name, date of birth, and all these other things. And also if they like callbacks as well, sometimes if I'm calling from a different phone number than the one that I'm calling from the pharmacy or the one that they're familiar with, I'll tell them, okay, we'll call the pharmacy and have them verify these things if you're more comfortable. Worst case scenario, I'll just have a staff member who is really, I guess that they are more comfortable with a particular staff member. I'll just have that staff member call them and tell them, okay, can you please explain to them that I called them and this is legit and things like that. So I think that's what's worked for me so far.
I heard some discussion over here, so I'm just gonna have a favor. Maybe Janet or
Oh yeah, just how to just be comfortable and natural, and in the words of Alex King, be real. When you're talking, that's like the key to it. Being so awkward, keeping it feeling natural about this stuff, having an introduction, telling why this program is, you know, we're sharing ideas of what's not working.
Yeah.
Janice likes to say you were flagged, and I like to say you are very important to your insurance company, and you have shown on this list that we want to give you extra attention. So maybe that if it got to the point where they just didn't want to feel special, I'll tell them that they were flagged. You know.
Yeah, that's great information. And actually, I was going to say that too. You could give information about the program in general and just be very careful with your choice of words to not indicate that they're necessarily like eligible for the program before you verify who they are. So without telling them that they have diabetes or hypertension or asthma or COPD, you could describe the program to them. And Whitney was saying, you know, leveraging people that they might already know, that they might have already received care for. Another thing I missed talking about that we're working on right now is we're working on creating a website, because sometimes people are like, oh, what's your website? Can I go on a website, or can I go, you know, somewhere where it's like publicly available information to kind of verify who you guys are. So if you have a website, you can kind of refer them, they can see that your face, your name, bios, things like that. That's another piece that we're working on, because we feel like, you know, that would be helpful to our patients. They can quickly go on and, you know, verify who they are. I've done that before when I get calls, who are you? I'm like, you know, at the same time looking it up, and I'm like, okay, they're legit. Yes.
Well, we were also talking about after trying to get them to understand who you are first, and then actually giving them, I know it's not, we were mentioning giving them a little bit of information about maybe their A1C or something of that nature. But what happens is usually the patients will say, well, who are you? And then you will explain who they are, who you are, and then you let them know about I mentioned LA here. And usually I would start talking about you were eligible for this program, but I had a gentleman that asked me, well, if I'm eligible, that's great. So what does that mean to me? And what are you going to do? And, you know, we just kept going on and on. So finally I said, well, actually you were flagged for the program to measure A1C high. You know what an A1C is? We're here to try to help you bring that down to goal. And then I kind of explained a little bit, and then he was fine. So it just depends on, you know, what questions they're asking you, and if you can nicely tell them.
Yeah.
If not, then I have to be honest. Let them know what I'm actually trying to do. And usually that.
Yeah, I agree. It's a good tactic for patient recruitment, but it's also, we have to be so careful, because this was lived experience at Virtual Pharmacist Care Center, and Steve knows this. In even saying, you know, you are flagged for telling you about your A1C, that piece of information about them alone is considered a HIPAA violation, because we hadn't, or, you know, a student hadn't verified their information first. And you have patients, like you said, who are so, that's when they finally agree to the program, because now they understand what you're talking about. But we also live in a world where we have patients who will then say, oh, you just, you know, I work in healthcare, or I know what you just did was give me information about myself without verifying who I was. And that's really why we wanted to talk about this last piece, because we know, like, in our hearts, and we're so passionate about providing them this service, but we do want to make sure, like, we protect you and we arm you with the right tools and resources so that you're protected as licensed pharmacists and technicians and your staff. And at the same time, we're protecting the patients and their privacy. And that's why a lot of times, if they want to know a lot more about the program, we'll try to describe the program in general and say, you know, like, without verifying who you are first, then I can specifically tell you what you're actually eligible for, what you are flagged for. But I can tell you in general, and then, you know, once we can verify who you are, and, you know, we can verify then what service was intended for you. Right, so I think with that, I'll give it back to Steve and kind of have him move on to our next topic.
That was a very robust session, a lot of great information, both shared by the speakers and by all of you, so thank you for that. Just to give you a little encouragement here, I've nixed the wrap up, so we will have to go finish as close to on time as possible. I think we're actually on. And we move on to our next speaker. So now you get to clear your mind for a second. We've been talking a lot about addressing the issues of concern or challenges that we've all had in the collaborative in general with patient engagement. Now we get to dream a little bit about what's ahead. One of the challenges we have with CMM is it's not easy to meet a bundle metric, right? You have to get, in the case of Valley Care, the initial pilot, VP under control, able to see the control on staff, if not contraindicated. It sounds easy, but it isn't always, and it takes time in cases. So in thinking about this next session, tools and resources to accelerate results from CMM, because let's talk about things that are both here and now and developing. So these tools may not be available to you tomorrow or next week when you return to work that you can implement, but they're moving very quickly. So we asked a couple of experts to speak about their different areas of expertise, including Dr. Scott Mosley and Dr. Bio Scott. I'm sorry, but let's just move along quickly by saying that Scott is a professor at the USC School of Pharmacy. His expertise is pharmacogenomics implementation. He's trained at the best institution ever, the best mentor ever in PGX, and has just been a remarkable resource for really any health system, including our own, in precision medicine, pharmacogenomics. So he's agreed to come and share with us some of the expertise and insights in how PGX fits in and aligns with comprehensive medication management. So please welcome Scott.
All right, so yeah, that was actually a really good biography without knowing it. That's really on my, especially as pharmacogenomics implementation in full transparency. So I have no conflicts of interest, but I don't practice in the community space. I don't currently practice CMM either. So I'm in the inpatient pharmacy. But what I'm sharing today are some of where the data and our evidence stands for using pharmacogenomics as part of a precision health initiative. And, really just knowing what evidence is strong enough to use clinically will allow you to determine if it's something that's right for your patients. As these do become, from the very first section, cost. That's what's really keeping it out of our clinical use right now. I think if you ask most people what the barriers are, I'll identify some of the major barriers, but you'll see that it's really just cost now. So some of the objectives, we'll talk about the applications that have demonstrated benefit, either because of safety, so avoiding adverse events or side effects, or improving effectiveness of the drug. I'll go through some processes for how a community pharmacist can engage with patients to help them obtain pharmacogenomic testing, or how to work through interpreting results and providing your recommendation. And then identify some of the common barriers of implementation. And it would be nothing that surprises you, but so this was a cartoon that was drawn in 2000, so just 3 years before the Human Genome Project completed. And anticipation was at peak. I don't know, actually it may have peaked even right after 2003 when it was published, but it's a person going up and giving this pharmacist prescription. It looks like a prescription. Here's my DNA sequence, and they're expected to know what to prescribe. That really was one of the promises of the Human Genome Project, and not exactly like this, but that's how they got people excited to invest the hundreds of billions of dollars that went into that. And it has improved human health, but not at the speed that we anticipated. And so what it really did look like over time was the 2003, it cost $150 million just to complete that one, piece together. You won't go through that whole cost, but these are costs for a human genome's whole genome sequencing. And those can be found for around $1,000 now as that bottom line. And NIH has been tracking this over time.
I'll tell you, from working with pharmacogenomics companies, the cost was about 400, and just recently meeting a couple of companies, one of them is moved it down to 330, and another closer to 250. And those are to give a panel of genes that can allow you to prescribe to make recommendations based on gene drug interactions. And there's 106 gene drug pairs that have clinical evidence where you can change the prescribing action based on it. So this Kishore et al. They put together a really nice, mainly if you're really interested in the steps for implementation. This is a good thing that they just put out using clopidogrel and CYP2C19 as the example of how the community pharmacists can utilize pharmacogenomics results. So, there's direct to consumer AGX testing. So that kind of in that top box and the second box down. So either get a new direct to consumer test, or it's already in the health record from previously doing it. The provider can order AGX testing. And that provider, while we don't have provider status as pharmacists, you can order these tests as part of a collaborative practice agreement. With other successful institutions that where pharmacists do the ordering, and it's part of that CPA. And that's the bigger part of it. So either way, one of these ways of obtaining genetic results, they end up in the electronic record. But if you ask physicians, similar to what we heard about like warfarin clinics and things like that, you ask them how comfortable they are interpreting pharmacogenetic test results, it's very low, and they actually do see this as a space for pharmacists to take a lead. So they, my role at USC, the only times that I do engage in any kind of recommendations, it's mostly on a constant service type situation. So I'm curbside by student health mainly, so for mental health services. And they are ordering these pharmacogenetic tests for their patients, but they do want pharmacists to review. So the strong evidence is, there's a resource called CPIC, Clinical Pharmacogenomics Implementation Consortium. They have what gene drug pairs have enough clinical evidence for guidelines. So you can find all of those there, and they are added and updated in real time. So there were over 60. Just last time I looked, I know there's more now. But the main areas of focus ones are cardiology. I say cardiology, but so Lisa has been excellent in preparing all this, and actually allowed me to add a slide I'll get to. Also neurology. I didn't focus on the evidence for stroke, but the drug is clopidogrel, and it does have a role in secondary prophylaxis. And I didn't think it because the evidence isn't as strong here clinically, but a major trial that was conducted in China did show that there's a benefit for certain population. And although it hasn't had a US trial, and our genetics patterns are different for our population, I think the benefit still makes sense. And so I'll highlight that briefly, but kind of think of neurology. Pain management, opioids and CYP2D6. Mental health, CYP2D6 and CYP2C19 primarily, although some of these other genes are kind of gaining more evidence, and that's in relation to SSRI hyperspreading. And there's been a couple of really exciting publications in the last year, one from Europe and one from the US, and I'll kind of go through this quickly, that shows that this can be beneficial in population health. So all these other ones, we have patients that already have an indication, already probably started a drug, and you order this test. And by the time you get it back, I'm telling you the turnaround time is about 7 to 10 days. It may mean that you don't get to make that change. So you need the information before you need to prescribe the pain and applications. But a couple of studies have tried just giving it on a large population basis and found both clinical and economic benefit. So real quickly, just to set the stage, it's based on genetic variation of our genes. So I won't go into that too much for you. There are, programs that continuing education programs that can explain this a lot better. I think if you're interested in learning more. But clopidogrel itself isn't an antiplatelet parent drug. It's activated by numbers of CYP enzymes, but it's really dependent upon CYP2C19 being a major one. So when you have CYP2C19 poor metabolizer, slow metabolizer, they don't get enough to be active on. They don't get antiplatelet effect, but it does lead to more clinical outcomes, thrombosis related outcomes. It was enough when they put ticagrelor on this is Prasugrel, TIMI trial. They did a subgroup analysis of CYP2C19, found that the patients that were taking clopidogrel had loss of function of that CYP2C19 or activating it or thrombosis. Yeah, they led the difference between those two groups, and ticagrelor was superior. But they found that difference could actually be explained by CYP2C19. So they put this in the package insert after that. It's really blurry, but the one thing that's not on here is that you should order genetic testing to guide therapy. The American Medical Association, ACC, AHA, none of them actually recommend either at this point. But if you do have the information, it's really up to you, and now you're legally obligated to do it. So it's the right thing to do, and now you can, a physician could be in trouble for not using it or not knowing how to use it. It's not So in cardiovascular disease, this was a real world trial. It's not randomized. These were all from institutions that implement pharmacogenomics as part of the routine care for patients after they have ACS event. That top line that really separates from the pack, those are people that had a loss of functional allele, CYP2C19, but still went on the clopidogrel. So they received the recommendation, you should avoid clopidogrel, choose Prasugrel, ticagrelor, and contraindications. But they still got a clopidogrel for one reason or another. None of them don't care what you say, they may have had some other concern. But those people overall did significantly worse or more events. The cumulative incidence on the y-axis is just the base of major adverse cardiac events or death and thrombosis. So in real world settings, you do see these true benefits. A randomized clinical study that we did a couple of years ago in the US did not show a benefit between genotype guided and standard of care. Now they were really ambitious. They wanted a 50% reduction of their events, and they just missed that. The places that were already implementing were not too concerned about it. Like it looked like there was a benefit, but to change clinical practice, to start covering tests for everyone, they said no. It's got to reduce it from 6% to 3% event rate within the next 12 months. So I think it went from 6 to 4 or something. So as the slide I had, I thought it would be interesting carrying the stroke and but it's called the CHANCE-2 trial conducted in China. Enrolled 6,000 people or more with loss of function alleles. And it's like, wait, is it ethical to give them clopidogrel? At this point, we don't know for fact. People were still taking it, but there were not rules being known. There's no evidence. This is the evidence to suggest that it doesn't perform as well as ticagrelor for minor ischemic students and TI. So with these data now, you may not see a randomized trial like this in the US. It's probably good evidence now. CYP2C19 loss of function alleles are higher in Asian populations, so around 50% of their population probably had this mutation, whereas maybe closer to 20 to 25% of an American population. So pain management, this was a real world trial as well. So these are all, some of these I think are randomized clinical studies. So the CHANCE-2 was the double-blind randomized placebo control. They even gave placebo for the ticagrelor. And so even if that was twice a day, they gave a placebo control with people who put it once a day. And so, but this one was more of a real world study of people with chronic pain on opioids. And some of these opioids go through CYP2D6 to become more potent opioids. You know, most of the patients in the study were actually on tramadol or hydrocodone, and both of those are dependent on CYP2D6 to go into more potent opioids. So tramadol becomes a tramadol, and hydrocodone is an hydrochloroquine. And so this is decrease in pain score when you look on the y-axis, and on the left side. The left side is the high-end intermediate flow metabolizers, so they're not making as much of that, the more potent opioid. And then the normal metabolizers are on the right side. There was no difference between those groups, which is expected because they wouldn't be expected to respond to the treatment. Yeah, I think one interesting note from here, so you know, if we want to talk about these later at the end, I could explain more detail. This is meant to just show you where the evidence stands. This is where you can get reimbursement. I'll tell you at the end, it's not ready. Really, it's hard to do. I think the people that have buy-in from an institution are able to get reimbursed. So Medicare and Medicaid do cover certain indications, and you can use evidence like this to request that it be covered. But I'll show you that it's not covered currently for all evidence. But I thought it was interesting that when you think of what's clinically meaningful in this, you know, in this case, an expert opinion, it's about a 30% reduction in pain. So the goal isn't zero pain score, right? But if we can reduce it by at least 30%, it's successful for most patients. And for the CYP2D6 guided group, it was 24% of those patients had clinically significant pain reduction, compared to 0% in the usual care group. And those are for people that were poor intermediate metabolizers, meaning they would have expected that the tramadol and hydrocodone were not consistent. So in mental health, so that, you know, United Healthcare covers it. We have to ask if Blue Cross Blue Shield covers it. I think not currently. You can write for prior authorization, and you can appeal for coverage for major depressive disorder after the patient has failed one therapy. So that's where it's basically from these data. There were some randomized clinical studies. This one was called the guided trial, and they used a proprietary algorithm. This is a private company. It was not transparent. So that's probably the biggest critique of this. And you know, it's I don't know that it can be replicated. You just have to kind of trust the artificial intelligence at that point, and that may be the reality of the future. If it can be replicated, then whatever, you know, goes into it must, you know, if it continues to show benefits like this, then it may be worth utilizing. But right now, the CPIC guidelines, which I'll give you some links in the later slides, those can be used, you know, without any kind of algorithm. There are very specific changes that are recommended for specific drugs. So it's mainly citalopram, sertraline for CYP2C19, and then there's paroxetine and fluvoxamine for CYP2D6. And now I don't see it, but I don't see as many SSRIs in patient. I think it sounds like most people in mental health have moved away from paroxetine, unless they've been on a stable for years or something. And it's fluvoxamine has very limited indications. And so, you know, what they found was that they had more response and more remission in the patients who had genotype guided care. So it's, you know, it was a positive trial overall. It was just not transparent enough for people to widely adopt it. You would have to go through a big elements of something. But they sponsored the trial, they conducted it, and it's basically just saying their proprietary algorithm might deliver outcomes, which just isn't not generalized. So now the population health, a really interesting study just came out a month or two ago from Europe. So a lot of several European countries offer pharmacogenomic testing to their population. So it's just a part of their health care. And so they've been using that to track adverse events and found that the people that are going in to get their pharmacogenomic testing are having less adverse events. And so they looked across 18 hospitals, 9 ambulatory centers, 28 community pharmacies. So just across the healthcare spectrum, this was across 7 European countries. So they did find a significant reduction in adverse event rates. And I think it was 28 versus 21%. So people who did not have genetic testing at that time, it's offered, but you don't have to do it, versus the people that did do it. Now, the people that did do it, I think the limitation and discussion point is that they're maybe just better in tune with their healthcare, and that's believable. But it's a positive signal and shows that it can work on a large scale population health. Population health. Okay, so what about the US? Okay, we have looked at it in the US. The teachers retirement system in Kentucky took it on to give the service, cover the cost of the service for their members, and found so their outcomes. I'm sorry, I posted this picture for, I don't know if everyone's getting the slide set, but the article does a really nice job of explaining the steps, but I see that most of these steps have been described here, like member engagement. The genetic testing, it's a swab, it's a cheap swab. They can mail it in to the company. It's, the CMM review part would be important, that would be our role. Most of these concepts, but I really encourage anyone who wants to start using it to just take a continuing education course similar to this. It's usually a day or two, some online work as well. And they'll should have every pharmacist is already equipped to understand this. But they did have these pharmacists conducting CMM reviews, offering and creating action plans. And so for those who underwent the action plans, they had 2%, 6%, and 15% reduction, outpatient, ED, and inpatient visits. And that led to a cost savings of $218 per member per month over this 32-month span. So it can work in the US, and these were retired folks, these were older patients. So more drugs, room for gene drug interactions, and even drug interactions. So it's mainly a way to enhance the care that you're already. Some resources. See, this one is where the guidelines are. So we have a guideline for each of our disease states. This is a guideline for when you have genetic information. There's nowhere in here that says we should order a test for this patient. There's currently no guidelines except in the realm of oncology when you need it for a very specific drug to target the patient, or a genetic gene therapy. Some of those examples we saw earlier. As far as some of these examples I'm giving, there is no recommendation for certain populations like there is for MTM or CFM or this CRMC. Some other places, so farm GKB, if you're wondering what's on the test and it doesn't have a guideline, you just want to know what the literature says about it, you don't have to search PubMed by yourself. This is an organization that curates all of the genetic data and puts it into some really nice tools and tables format it's easy to read. That clopidogrel diagram with the liver cell and platelet came from farm GKB. It's a really great resource. If you're wondering how do I collect some data for this, I don't want to make my own. I don't even know what outcomes to collect. Pharmacogenomics Research Network does share these. There's some freely available ones. I'm trying to think what's not available unless you remember, but you can sign up as a member as well and have access to webinars and all kinds of other support tools. I saw this as one of your partners on the live stream Steve was sharing earlier, get the Men's Right Institute. They also have, I think, some interest in advancing pharmacogenomics in their service. So I found some really nice, so I'm not a member of it, but I was able to access some of their materials and their past webinars, not watch them, but I saw the titles, and they actually did a webinar with one of the coordinators from that Teachers Empowerment System. So I thought that would have been an excellent one to view if you are a member of that. So really, it's only, I don't know how exciting this is to you, but this is really exciting to me. But the caution is don't get too excited, don't oversell this. I think that's how the disillusion happened in the early 2000s when there's so much anticipation that it didn't produce immediately. But strides are being made, and the evidence is building that this is a service that can improve health or well-being, and also there's cost savings associated with them. So it's just a piece of it. So I put in the middle. It's like it's all these things that you're already doing, but now considering how pharmacogenomics might influence one recommendation for another. So yeah, I think it was enriching seeing it rather than directing it, because even the papers were all really excited when they published pharmacogenomics. We'll call it CYP2D6 guiding, CYP2D6 directed therapy. And the more I think about it, the more soft language we should use for this segment. CYP2D6 informed therapy, maybe, but we still take into consideration CYP2D6 inhibitors, like those actually change how you think somebody will react to the drug. Their body size. So it's all these other things, and they're what the data that's what I've talked about. So you're thinking about this benefit risk ratio, risk benefit ratio. A benefit or something positive I have seen in the recent publication is they're including quality of life measures. And I see that you Steve highlighted your submitting a grant to the Glory Network, which is awesome. We really hope that comes through for them too. Because that is kind of what's missing. It may not be that it's so much of a difference between cardiovascular event rates, but maybe there's difference in minor bleeding limits, which wouldn't show up in a clinical trial, but it's distressing to patients. And so getting their feedback on their health related quality of life will be important for the future. So the barriers, there's a lack of indications to get tested. There's not a lack of evidence for what to do once you have them. High quality gene drug applications of limited populations, so that used to be a barrier, I would say maybe not so much. High quality gene drug results and turnaround time. The provider lack of knowledge and how to translate the results. That's still kind of a problem. I think that's something they are relying on pharmacists to help with. And the EHRs are prepared to take in these test results. So you get a test from a company and they give you a patient portal, and that's great, but it's not going to trigger any alert in your health system when you order something. And so there are the companies that get the test results to the patients and providers. They do have ways to translate it to Epic, Cerner, whatever other large systems, but they can also work with smaller systems or something that help integrate, just like they would a drug allergy or something like that. They can trigger an alert. And then reimbursement. That's really the big one. So I'll say that, you know, the high quality gene drug applications are limited, the population's unlimited before. These are pretty major problems, cardiovascular, mental health, pain management, and now just general population locally, adverse events in a large population. The turnaround time could be weeks, and it's really coming down to about a week or so. There's even a point of care testing for CRMC for those patients. If they have to do something in the hospital or store, the reimbursement, I'll say, will make progress. This was a bill, California bill that was rejected last year. So passing unanimously is crazy. I've never heard of unanimous anything these days, but the government signed it and stated, you know, that it would cost like $20 billion up front. It would be $10 billion annually. If that's not in the budget, we instructed the House and Senate to revisit the budget and kind of come back to something else. And so they have, on the national level, we do have this right drug dose, which I might be familiar with. But pharmacogenomic testing is a part of that to reduce adverse drug events. It's being proposed at the state level. If they did rework that bill, I see an active bill now that they're just calling Medi-Cal pharmacogenomic testing. So while you can still submit for certain very specific indications, you this bill would actually cover it as a part of the Medi-Cal service, and with the goal of these kind of population, like the teacher retirement system, service in Kentucky, kind of like what they were doing, but for the Medi-Cal population. So I'm excited to see where those help us advance. But the recommendations are, you know, we can use existing resources. There's nothing that you have to figure out on your own to do this for your patients, especially those who come with a genetic result of cancer. The time, you know, should invest just everything. Patients and physicians will need some education. Think of how you'll integrate it into your EHR, or have a systematic process of how you'll know to review pharmacogenetic tests if they're available, and then record metrics. So a lot of these studies that have shaped the guidelines are real world implementation. And so I don't think we're going to see a clinical trial for all of these specific indications. Just like we don't see clinical trials for, you know, people with reduced renal function in every situation. Once you have a safety concern, I think it's working fine, even if it's found in real world evidence. So it sounds like you already have a lot of data collection here, and if you need templates that are available, like things PGR. So, thank you. Very good.
Okay, so we are not going to have the discussion section, so we'll save some more time there, because I really want to give Bob Trying plenty of time to talk about remote therapy. I think it should be a very great interest to all of us. For a quick introduction, Bob is a man of many talents and expertise. I guess I can call him one of the most innovative people I know. He's attended many well-known universities: Wisconsin, Stanford, University of Minnesota, UCLA. He's a CPA at Ernst & Young. He's a corporate executive, advisory board consultant. There's a lot I can read about in this bio that he shared with us, but it's sufficient to say that he's been an executive leader at all levels and has produced incredible impact in quality outcomes, patient care, and just always has brilliant ideas to share on how to advance not just pharmacy practice, but healthcare as a whole. So really is a privilege and honor to welcome Bob Trying to share his take on our team at Smart Caps. So please welcome Bob Trying.
So I'm impressed. This is the first one of these that I actually attended live. And it took me back to the days when I was a senior exec at Emerson Health System in the Midwest, up in the Midwest. And they at the time, they were ranked one of CMS's studies, top 5 for clinical quality and top 5 for low cost in the country. And I would say that, yeah, the presentations that I've seen and enjoyed today would do well. I understand. Compare favorite. So, I'm going to talk a little bit about the evolution of RTM. It's pretty new. That's remote therapeutic monitoring. Talk a little bit about the solution architecture, tiny bit about clinical, mostly about the operational process, people, technical, getting started. Some simple suggestions. Have a couple of specific learning objectives. One is to align RTM with CMM. I think it aligns pretty well. And outline a framework for getting started. So yeah, for myself, I guess the only thing is that I do have a relationship with our XCAP. I made some more slides today. I've advised them since the beginning, basically, and before the beginning. My other work that I do is in research, data research, multimodal genomics, data. So why remote therapeutic like LDL monitoring? So you know better than most that pharmacists are increasingly on the critical path of all care delivery. I saw that at Gunderson. I had executive responsibility for the community pharmacies, and I was in the reviews, every quarter of every piece of the organization, including the hospital pharmacy, and it was completely embedded into the clinical activity of the organization. And it really illustrates the importance and the value of pharmacists, and I would also posit patient in terms of engagement and adherence, and it helps to the patient become a more active participant in their own care with feedback. As we've heard, and we all already know from experience, pandemic accelerated remote patient monitoring. That's the parallel to RTM. Expanding the use of both telehealth and home-based physiological monitoring. Personal anecdote, I happened to be with my brother a few months ago when CMS had authorized the use of continuous glucose monitoring. He done pretty well. With the conventional things that he had to work with, but he came alive with continuous glucose monitoring. In turn, he seemed to be exactly like his own doctor, which I think is been what they're doing. It can be a good thing, and I think that having that information brought to the patient, whether it's physiological or adherence data, can be a useful thing. I wanted to talk about a few other sort of trends and observations. So we all know about mobile phones, digital devices. They're having 2 impacts, probably more, but they're increasing visibility into the patient's activity and behavior when they're outside of the clinic. So, how much time do we get to talk to them, to have them in the clinic? It's not a lot of time. Devices are practically 24/7. And if we get them to work, it provides a vast amount of interaction, possibilities, and information. I think that's part of the promise. RTM didn't just get started this year with RTM's changing billing, with CMS's changing billing. It's been going on for several years. I'm familiar with specialty service providers that have implemented it in high risk, high cost use cases, specifically post-transplant, specialty meds, HIV care. These are cases that involve tens of thousands and more of dollars to be successful. You don't want to get it wrong. And so if there were the funds available before CMS started to fundraise to get it done. And that basically led the process. More recently, CMS now has begun to support less costly But important cases in terms of musculoskeletal, respiratory, and material health. We'll talk a little bit more about that later. And we anticipate more use cases coming down the pipe. The thought is most likely the metabolic area, combining both RTM and RPM, but that's yet to see. So what's the relationship, or how does it work with the work that you guys are doing? And it's actually a pretty deep relationship, because most of the work in implementing RTM is not putting the technology together. It's having the legal agreements, the collaborative agreements together that make it possible. They're working relationships between pharmacists, clinical providers, and process and staff operations to identify patients and work with them. And one thing I've been very impressed with today is just the work that's being done and the understanding that's there with how to engage with patients. And I think that will give you a leg up for sure in terms of getting into the RTM space. What's the technical solution going to bring? Well, the advanced solutions, they're going to automate the collection of adherence data real time. They're going to automate the reminders. You can program reminders and initiate two-way communications if you want to do that. It's going to collect data relating to cost, the physiological biomarkers. If you're adding a RPM type device as well, and medication adherence. So it's a collection of a lot of data that can be leveraged then to analyze response of quality of care as well as engagement behavior. And it also provides administrative data in the terms of the CMS program to help automate billing where payments discovered. The other thing is, I think, and it's really, this was the thought that triggered in my head when I was listening to the various discussions about engaging with patients, talking to patients. The thought that having that connection with the patient in terms of their adherence to their therapy, combining with the possibility to initiate initially automated communications, and then sending a link, a lot of this is on texting, sending a link to take them to a trusted site where they can talk to somebody. I think there's real opportunity in helping to solve the problem that we've been talking about quite a bit today. So I think there's something to come. So in terms of just contrasting RPM and RTM, and this is from the view or through the lens of CMS. They approved payments starting in the beginning of 2018. It developed, and especially some of the home-based devices, and then the pandemic struck, and it really was. They started allowing for payments on RTM. For those two cases initially, respiratory and musculoskeletal. They announced it in November. They started in January 1, 2022, and then announced it in November that we're going to add for the billing for people and patients and other, pharmacists and other non-prescription professionals, and that really has accelerated progress in development of this and during this year. They added in the beginning of this year behavioral health. That's also billable, but you need to work it out with your territorial map on that one. A little bit more detail on the differences, more prescribers on RPM, on RTM than there were on RPM. RPM has been covering a lot of the high volume conditions, and it's a much more limited list for RTM. And in terms of the code, there's one extra code that the RPM solutions give, and I'll show you that in a moment. How does it work out in a billing cycle? Well, the first two codes are basically supported automatically with the digital data coming out of the system. So the first time the patient uses the product, takes off the vial, a cap, and then when he reaches, if she reaches 16 days in a month, those are the first two billing in the cycle. And then the second two are the two potential engagements with pharmacists or other professional during the month. Has to be at least 20 minutes. Some of that has to be live, and that adds up to approximately $143 a month. And in terms of RPM codes, they have that extra code of interpretation and analysis because of all of the devices, additional devices that are used for physiological biomarkers. Now, there's a lot of devices out there, so these are mostly on the RPM side. This is just 15 of them, and more coming every day. And there's the ability to customize where you have a focus in terms of the right physiology device. If you want to combine it with the RTM device, and so if you do decide to start this path, you're going to want to probably get some advice, some assistance in terms of making those choices and helping you to design the infrastructure. And that's not just in terms of the devices themselves, but there is sort of a product management distribution chain to this solution. And then there's a software and integration components. And so the more advanced providers of service in this area can help you through all of that. The technology doesn't really take more than a couple of weeks, really, to get you started. And it's more the legal, the design and picking of the application that you want to do. And putting it in the context of this particular care model, which is pharmacy specific. Getting from say 2 o'clock assess to implement, or at least through planning, it could be 2 or 3 weeks. But more likely it's maybe a 2 month, 3 months to get to the point of implementation because of these other aspects, and depending upon how much you focus someone's time on, if it's too part-time, so it's all doable. And each time you go around that circle, you pick up more information, you can modify your approach a little bit, you can start collecting enough data to figure out what you got, how to leverage that, and it picks up. But getting started, you probably want to start simple in terms of, don't go for the hardest cases because you're trying to learn the system. So some relatively adherent patients, perhaps, get it implemented, get comfortable with it, get your the various elements to where it's working, and then add more complex patients, add another use case if it's available for you. And then you can use in the case of CMS, you can use the system to generate data for at least some of the billing process, and then combine it with your pharmacist timekeeping for the other 2 days. What's coming? CMS is talking a lot about medication adherence and diabetes, hypertension, cholesterol, specifically statin use coming up next year. Is that going to go right to RTM? What I hear is likely not. It's likely the next use case and next conditions will be metabolic, especially if you combine with RPM. Medicare versus Medicaid, about 18 states will compensate for RTM, not California at the moment, but you may also have payers that will do that for RTM. Of course, there are the value-added service providers if you're involved with that yourself and research and pilots. So that's what it looks to be coming, and I've got a few questions. So yeah, I'll give you a chance to read these and then anybody who wants to can just shout out an answer. Get me clue, I already did the wrong answers. This one. But all of them are. So what are recommendations for selecting, for getting started selecting, managing, billing eligible patients? This is a big run out of them. Somebody want to answer it again? Well, if I was right, I would guess 3 because I mean, if I was right 100%. AC and E were all mentioned. And what conditions or medications might take advantage of RTM going forward? Well, I go with all of them. The newest ones are polypill, but they're out there. Yeah, I think that was it. So yeah, if anybody has any questions, I don't know if these get handed out, but feel free to reach out to me and I'll do anything down. Thank you. Another question?
One quick question. For RPM, I know it's an approved benefit for Medicare, but these days, most of the Medicare are the Advantage plans. Does that benefit go away, or how do we navigate the Advantage plans?
You know, I can't tell you exactly on that. I know that the billing is really more for the fee for service, but I can get that answer for you. So maybe I can give it to you.
I can email you.
Yeah. Or you can email me. Yeah. Thanks.
Okay, thanks so much, Brian. Okay, so we are in the home stretch here and we'll be now wrapping up with focus on diabetes self-management and support services. This is something we're working on with the California Department of Public Health. As I mentioned top of the meeting, we have some contract funding to support some specific local health jurisdictions where DSMES is very difficult to find. So thanks to our engagement now with Colette Vivian, am I saying it right? I was getting that wrong. She is leading this program for us, has just done a remarkable job. So she'll be sharing her findings and getting some feedback for you all on how she can best execute this program. So just in brief, I'll be very brief on this one. She is an alum who did complete a residency in community pharmacy and has gone on to take a number of jobs. That's really how we came, right? We've had many career positions in a very short amount of time, which I think has really added to her knowledge of the breadth of pharmacy. So it really enabled her to quickly step into this role and help fill the gaps between what CDPH wanted and what our needs are in community pharmacy. So with that, thanks. Welcome to us.
With Steve and the CPH Prevention Forward program, helping to implement and provide sustainable DSMES services within 4 local health jurisdictions, specifically Fresno, Madera, Monterey. Now, financial relationships that are part of the educational content that's being presented today. Just a few learning objectives for the presentation. I'm going to be reviewing key steps in terms of the implementation process, specifically within community pharmacy settings. I'm going to be identifying proven benefits of DSMES services as well as disparities in the availability of these services. Providing a brief summary on the current Medicare Part B DSMT coverage guidelines, listing potential barriers to initiating and sustaining these services, and lastly, diving just briefly into supplemental services like DPP, MNT, and CBD screening. We'll be reviewing a process map depicting the step-by-step approach in terms of implementing the services. A brief introduction to DSMES, including background as well as disparities like mentioned before. The 6 national standards for DSMES, which would be the most current 2022 standards. Reimbursement and referral requirements. The application process that a community pharmacy would have to go through in terms of gaining ADA education recognition. Potential barriers. The CDC's National Diabetes Prevention Program, medical nutrition therapy, emphasizing the importance of data collection along the way, comorbid conditions, and lastly, reviewing some feedback that we've received thus far. So this is the first part of a step-by-step approach that I've developed within this process map. So first things first, the service needs to be in alignment with the current 2022 national standards, which I'll be reviewing fairly soon. And there must be a DSMES team that is in place, and we'll talk about requirements in terms of team members and whatnot fairly soon from the presentation. And the team will be tracking and reporting specific behavioral as well as clinical outcomes along the way, and that can range anywhere from changes in A1C, weight, blood pressure, lipid values, and whatnot. The pharmacy will have to make sure that there's a process in place in terms of quality improvement, as well as marketing the services to patients and providers within the local community, keeping in mind relevant patient level barriers, provider level barriers, as well as programmatic barriers. The treating provider, the provider that will be referring the eligible patient, will either have to be a physician, nurse practitioner, or physician assistant that is currently managing the patient's condition and has diagnosed them with either type 1 diabetes, type 2 diabetes, or GDM. And it is that provider that will go ahead and refer the patient to the local pharmacy that is offering the DSMES service. An initial cycle lasting anywhere from 1 to 6 months must be completed prior to the community pharmacy applying for education recognition through the ADA. And that process usually takes up to 30 days. And it's then that the quality coordinator designated within the DSMES team will receive notification of either obtaining approval or the need for provision of additional documentation. Once recognition is obtained by the ADA, the pharmacy can go ahead and bill for the DSMES services, and we'll be reviewing billing in just a bit. There is an annual status report that will need to be submitted to the ADA on an annual basis, and the community pharmacy won't have to apply for recognition renewal for another 4 years. And, like emphasizing the importance of data collection, marketing, various types of sustainability measures, all of that really need to be continuously emphasized and evaluated periodically. Just a brief introduction. So as we know, diabetes is a health, social, and economic burden in the US. Currently, over 37 million Americans diagnosed with diabetes, and it stands as the 7th leading cause of death, increases the risk for major health complications, and costs the US over $300 billion on an annual basis. DSMES is a cost-effective tool and service that is evidence-based and has been proven to improve health behaviors as well as outcomes, and really focuses on providing diabetic patients with tools, skills, and confidence to be able to sustain self-management behaviors. Has been proven to reduce hospital admissions, readmissions, as well as healthcare costs, as well as linked to significant improvements in A1C, up to 1%, lipid profiles, weight, and blood pressure. Touching on the disparities in terms of availability of DSMES services. So currently in the US, DSMES is offered within 56% of counties.
62% of rural counties do not have a service in place though. In terms of beneficiaries, less than 5% of Medicare beneficiaries have been placed in some type of DSMES services, and less than 7% of privately insured medications. So community pharmacy settings can really serve as vital solutions to decreasing these gaps in availability and increasing access. This is a brief overview of the 6 national standards that I mentioned, and it is these 6 standards that community pharmacies must make sure that they that their curriculum and their DSMES service is in alignment with. So standard 1 will focus on supporting the DSMES services, and this mainly deals with making sure that the DSMES team has a sponsoring organization, in this case, the community pharmacy, that will provide leadership support, various types of organizational resources, as well as helping to address the needs within the community. Standard 2 will focus on population and service assessment. So this is where the team really needs to sit down and evaluate their target population to determine the various types of needs and preferences within that target population and design the delivery of their services around that. Standard 3 focuses on the DSMES and team members. We'll be talking a little bit more about that in just a bit, but just to mention, a quality coordinator needs to be designated within the team. Clear identified roles based on evidence-based design and delivery of the service. Standard 4 is going to focus on the design of the service, and that's mainly going to focus on the need for an evidence-based curriculum that should be in place. Standard 5, emphasizing the importance of person-centered DSMES. So again, very similar to standard 2, focusing on the specific participants' individual needs and concerns, and making a collaborative decision in terms of how the curriculum will be designed to best serve the participant. And lastly, there will have to be some type of continuous quality improvement process in place to evaluate outcomes and data. So there is going to be various types of reimbursement requirements that Medicare Part B has in place. DSMT is the equivalent to DSMES. It's just specific terminology that Medicare prefers to use, and stands for diabetes self-management training. The pharmacy has to apply to become a Medicare Part B provider, and must also, like I mentioned before, either earn recognition through the ADA or accreditation through the ADCS. In this presentation, we're focusing solely on ADA recognition. DSMES services are entailed with 2 types of trainings. The first would be an initial training, and that includes 10 hours within a 12 consecutive month period that would be provided to the participant. Following that, 2 hours of follow-up training can be provided on an annual basis. And like mentioned before, a referral is required for this for eligibility. These are some of the different types of procedure codes, differing based on if they're presented on a in terms of group audiences or on an individual basis, and they are based on 30-minute increments. As you can see, the national average fee schedule is listed as well, and limitations in terms of how many hours can be provided on a daily basis, depending on which code is used. In terms of marketing and sustainability, establishing that referral network is key, and making sure to create and update promotional materials periodically. So those materials will serve as routes to empower not only the providers, but also patients. So a lot of times, based on feedback that we've received thus far, we've learned that patients may sometimes be the one that are reaching out to their providers and seeking that referral once they learn about the availability of this program and its benefits. Like mentioned before, there is an online application process that the pharmacy will need to go through in order to gain recognition, and thus in order to bill for their services, DSMES services. So various types of documentation that needs to be submitted. There is a $1,100 initial application fee, but that is for the 4-year recognition period, and they don't need to apply for another 4 years later. Different types of requirements in terms of the curriculum, making sure to be in alignment with the standards. And the AD really does provide great resources in terms of making that application process very smooth and easy, making sure that all those check boxes are marked and whatnot. Like I mentioned, I wanted to just touch upon the DSMES team and specific requirements within that area. So at least one of the DSMES team members must be a registered dietitian or RDN or a pharmacist or have BCADM or CDCS credentials. So that's something to keep in mind. There are also certain competencies that must be completed before joining the team. So non-BCADM or CDCS team members would have to have 15 CE hours completed prior to joining the team related to diabetes related subjects. And if they don't, they can go ahead and complete those within 4 months of joining the team. Also, we talked a little bit about community health workers. Community health workers can also serve a role within the DSMES team, primarily as diabetes care coordinators. A few barriers that may come along the way that the providers, individuals may face, as well as the DSMES team members may face. So anywhere from provider level barriers having to do with the referral process, individual barriers related to access and participation. And again, the ADA provides wonderful resources that the team members can discuss with the patients, provide to the patients to help them overcome barriers, whether having to do with financial resources, transportation resources, healthy eating, physical activity, things like that, healthy coping and whatnot. And in terms of underserved communities, just touching upon the fact there is an increased prevalence of diabetes among those with low socioeconomic status, certain racial minorities. So DSMES services can really play a vital role in different ways. I wanted to briefly just mention that DSMES services can be supplemented with the CDC's National Diabetes Prevention Program. Very similar to DSMES, there is a recognition process that must be achieved. So the pharmacy would have to apply for CDC recognition. This application, though, is free compared to DSMES. There is a curriculum that needs to be in place. The CDC offers their own curriculum that can be utilized by the pharmacy, and there are certain proven benefits that DPP has demonstrated over time. And there is something that the CDC provides that pharmacies can use to calculate cost versus benefits when deciding whether or not they want to implement DPP within their setting. Medical nutrition therapy is also a wonderful service that can be in place and has been proven to improve outcomes when complementing DSMES services rather than each service being offered alone. The only limitation is that these two services cannot be billed to Medicare on the same day. So it is a comprehensive, cost-effective nutrition therapy service that is individualized, however, can only be provided by a registered dietitian nutritionist, which, after speaking to a few pharmacies that have implemented both MNT and DSMES, is possible, especially if they have an RDN already within their team. Again, MNT, like DPP, has proven to demonstrate quite a number of benefits and improvements in A1C. Data collection is going to be very important and needs to be continuously emphasized, especially by the quality coordinator within the team. As we know, outcomes can help not only measure the impact of the services being provided, but help us identify different areas of improvement in terms of optimization of the delivery of the service. Lastly, wanted to just touch upon cardiovascular disease and comorbid conditions. CVD does serve as the leading cause of death for men, women, and those of most racial and ethnic groups in the United States. And diabetes has been shown to be one of the leading CVD risk factors, along with hypertension, hyperlipidemia, physical inactivity, as well as unhealthy diets. So it's a wonderful idea to incorporate CVD screening within the provision of DSMES services and community pharmacies, whether that would be through the utilization of the ASCVD risk estimators, and sitting down with the patient, gathering various lab values, information from the patient, and calculating that 10-year ASCVD risk. Point of care testing through hyperlipidemia, hypertension. So these are all wonderful ways to perform CVD screening during the initial encounters with the patient. Lastly, I just wanted to give a brief overview of the types of feedback that we've received. So Steve and I have reached out to different types of pharmacy settings, healthcare professionals that have either already implemented DSMES services within their community pharmacies, or they have worked with DPP programs, have a lot of support feedback to provide. So we've gained a lot of wonderful, helpful information along the way, whether it has to do with the application process, common challenges, best practice pearls. And overall, thus far, it seems that everyone does agree that the application process, whether through the APA or the ABCDS, is fairly smooth. Lots of helpful resources to make that a smooth and easy process. Common challenges, it's agreed upon that reimbursement can serve as a common challenge, but there are ways to overcome that, building that referral network, maintaining and sustaining that type of communication and relationship with the local providers has helped to allow us to overcome that barrier. These are some of the organizations, healthcare professionals, pharmacists that have been so kind enough to provide us with feedback and support along the way. So just wanted to take a moment to thank them. And that is my presentation. So I'm open to any questions later or now. But yeah, I don't know if anyone has any questions right now.
We have a question. For the registered dietitian nutritionist, can they be a certified nutritionist specialist? That's a master's instead of a bachelor's.
That's a good question. All I've come across is RDN. I think at one point certified nutrition specialist could, but I think most up-to-date guidance says that RDN is the licensure that's the. I can check.
Yeah, we only have RDs, and if anything, we have RDL. We will hire RD eligible so long as they're qualified and getting but outside of that, we don't. And I don't know if it's in most of our contracts it says RP anyway, so it doesn't say that.
Any other questions?
I want to know if you does that how to register?
For the ADA?
Yeah.
Sure, I can send that link to you. Thank you.
Yes.
Oh, yeah.
Okay, so we are ready to close out. Like I said, I was going to force you all to share with me your requests, offers, and commitments, but we only have 5 minutes. So I think more importantly, I want to thank all the folks that participated in the session today, all the wonderful speakers, really donating your time and expertise to this important effort. So greatly appreciate that. All of you who attended, your comments, your engagement, your suggestions. we've written them down, so we will share those back with you, especially some of the patient engagement advice that you all shared with each other. I think it's worth reflecting on and figuring out how we can adapt those to our practices. I would be torched if I didn't thank Lisa McDonald for her coordination of this entire event, from the pre to now to the little details to carrying a 100-pound status here for our photo. She's really done everything for us. So let's thank Lisa for putting together. Like I said, I usually ask for something like this, but I'll just put this in your mind as you go out and put your bet on the roulette wheel or the blackjack table. Think about these things. You know, what are some key insights you can bring back to your organization this meeting? Do you have any requests? Let us know. If something came up and you thought, yeah, I'd like to do something a little bit different in this collaborative, please let us know. And as many of you have already done, if you have any offers, any ideas, best practices, share those with us as well. And when we reconvene again in our coaching sessions and our monthly webinars, we're going to hear from you on what you've actually committed to execute and operationalize some of this work that you've heard today. At the end of the day, these learning sessions are anchors. What really needs to happen between learning sessions is action. We're now in the next action period between this learning session and the fall learning session. So if we don't do something with what we learned today, it's all for nothing. So we want to hear progress as we go through the next 7 months on what you've been able to do with this information that you've gleaned. The last one, we always say this, what can you do by next Tuesday to advance what it is in advance in regards to this collaborative? So who's that person you want to contact? Maybe it's someone in this room. Maybe it's someone in your C-suite based on an idea that you had. Maybe it's a collaborator, stakeholder, potential partner. Make that commitment to reach out and make that happen first step. Great. With that, I want to thank you again, everybody, for attending. I think we have, where is it? I need to get to it. If you haven't filled out this survey from the LA County Department of Public Health, please do it. It's actually vitally important to them. Again, they're trying to track what is the uptake in terms of adoption of CMM, interest in CMM, and among the LA County pharmacists. And I think, Jessica, is this only LA County? Is that so? You can, yeah. So only. Oh, anybody can answer, regardless of what county you're in or what state, please answer. We'd like to get your feedback. So again, thank you all, and have safe travels. Good luck with your gambling if you're gambling, and we'll convene soon. Thank you very much.